सिद्धार्थ सिद्धार्थ
ओपन करू मी?
नको थांब. तुझ्याकडे इंट्रोडक्शनचे स्लाइड्स आहेत ना?
नाही सर, कशावर दिले तुम्ही मला?
अरे मेल ला पाठवले होते मी तुला.
मला नाही भेटली.
सिद्धार्थ
ओपन करू मी?
थांब एक मिनिट, मला हे इंट्रोडक्शन ओपन करू दे.
मला नाही भेटली अनिल सर.
अरे तुझ्या ह्याच्यावरती पाठवली होती मेल वरती.
मी तुम्हाला मेल आयडी परत एकदा देऊ का?
परत पाठव.
मी अटेंडन्स साठी ओपन करू?
थांब नको 2 मिनिटं.
मैंने डेस्कटॉप पे डाला है, लैपटॉप पे डाला है, किसके लैपटॉप? नेट बैंकिंग करता हूँ तो वही का सिक्योर। हेलो सर, मेरा भी वही स्टार्ट।
हाँ चलो बोलो.
करो?
हाँ
फोन में भी है ऐसा टाइप पेज।
सिद्धार्थ ओपन कर.
हाँ केली.
Yes, we can start.
Good morning, friends. Good morning, friends. I welcome you on behalf of Indian Medical Association CGP Subfaculty Mumbai branch. Today we have got multi-speciality CME. We have got expert. They will share their experience and update us with the latest treatment and mode of today. And now I'll tell you about the next CME program. Next Sunday, we have also got the CME program. You will be updated soon. And before we start the program, let our enthusiastic, ever-smiling President, Dr. Jitesh Mehta, welcomes you and update the upcoming events of IMA Mumbai branch. Over to Dr. Jitesh Mehta.
Thank you, Dr. Usha, and good morning to every one of you. Now we are all here to listen to very learned people. We shall be having 5 lectures today. And well, friends, the spirits of Indian people are very high today. We have got a lot of precious metals coming in like gold and bronze. And it has been a record-breaking event for India at the Olympics in Tokyo. And we are all very happy and proud to see our players perform so well. So let the spirits remain high, and we pray that this continues. I would like all of you to participate in the next Sunday program of Independence Day, where we do flag hoisting at IMA. After that, we shall be having some musical program. So all those who can come over to IMA, do come. I shall now ask our Dr. Anil Awad to start this program by introducing the first speaker.
Thank you,
Dr. Awad. Please take over.
Yeah. I'll just share the slide of introduction.
Sure.
Yeah. Good morning, friends. We are beginning with Dr. B.A. Krishna. I just spoke to sir. He has a very extensive biodata, which I have to cut short. Make it fit on the screen. Dr. B.A. Krishna is the Director, Nuclear Medicine and PET Imaging at Lilavati Hospital and Endocrine Cancer Specialist at S.L. Raija Hospital, Mumbai. He is Honorary Professor of Nuclear Medicine at BYL Nair Charitable Hospital since 1998. He has worked with Tata Memorial Hospital for 13 years and was Chief of Nuclear Medicine at PD Hinduja Hospital and head of the Department of Nuclear Medicine, PET Imaging at Bombay Hospital Institute of Medical Sciences. He is a member of the advisory panel for setting up of National Cancer Institute of Government of India, member of the promotion committee of senior scientists of BARC, and member of the review committee of the Tata Memorial Hospital. He is pioneer in starting many new techniques in our country, like radioimmunoscanning in colon cancer, octreotide scan in endocrine cancer, leukocyte scan in infection, epilepsy scan, gamma camera scan, glucose PET scan, etc. He is on the review panel of JAPI, Indian Journal of Cancer, Indian Journal of Radiology and Imaging, and Indian Journal of Surgery. Throughout his illustrious career, he has received numerous awards. To name a few, Thinking Minds of 21st Century Award by American Biographical Institute, International Distinguished Leadership in Teaching Award by American Bibliograph Institute, Homi Bhabha Memorial Oration Award, Kinari-Wala Cancer Research Awards, and many more. He has treated close to 2,500 thyroid cancers and is senior teaching faculty of International Atomic Energy Agency, Vienna. Today, Dr. Krishna will be speaking to us on nuclear medicine in thyroid disorders. Over to Dr. Krishna.
Thank you very much for inviting me for the CME session. Is my slides are seen?
Yes, sir.
Yeah. The thyroidology through the isotopes is the first imaging and diagnostic and therapeutic specialty that started way back in 1938. So clinical medicine, as far as nuclear medicine is concerned, started with thyroidology. It was in 1938, Professor Seberg invented the radioiodine 131 at the Berkeley University and gave it to the clinical medicine. So for that, he got a Nobel Prize in 1951. And after that, in 1950, was the first machine produced by Professor Benedict Casson, who is called the father of body organ imaging in clinical medicine. And this machine was able to pick up the thyroid picture through a radioiodine isotope, which you see here. This was the first thyroid scan by Benedict in 1950. We have moved on from there, and a lot of new equipments have come. And the one which we use currently is called the gamma camera, which when you give a radioiodine, which localizes in the thyroid, from there the radiation comes, and these radiations are picked up by the gamma camera detector, converted into electronic signal, and an image of a thyroid gland is obtained on a color paper or on an X-ray plate. We also use what is called as thyroid uptake probe. Now, this probe is used to understand biological half-life and iodine molecule when given to a patient. 2 hours, 24, 48, 72 hours. What happens, how the thyroid handles the iodine molecule is made up by this probe. This probe today is not very commonly used. In my earlier days in 80 at Tata Memorial, I used to use this conventionally. So today the latest one is called a thyroid gamma camera. If you see here, this has been so beautifully modified that now it is kept in a thyroid clinic at the Massachusetts Institute. And everything is done at the endocrine lab, endocrine OPD clinic itself. So these are the machines that we use to get the images. In 1977, great scientist Rosalind Yalow gave to the world T3, T4, TSH. That was the birth of radioimmunoassay using radioiodine labeled compounds. She got a Nobel Prize for that in 1977. And we use these two techniques even today for all the diagnosis of thyroid disorders. Coming to the thyroid scan itself, types of thyroid scans are, one is a metabolic scan, second is a morphological scan. In the metabolic scan, we use radioiodine isotope. In the morphological scan, we use a technetium isotope. In the metabolic scan, the radioiodine, when we administer to the patient, it tells us about the trapping of the iodine molecule inside the thyrocyte. After that, how does it undergo organification? And finally, production of T3, T4. All these functional data within the thyrocyte is given by the radioiodine scan, Hence, it is called a metabolic scan. We are in effect studying the metabolism of iodide molecule in the thyroid gland. In the morphological scan, we do not get these information, but we only get the information called size, shape, and nature of a nodule. That is the only information we get. So this is called as a morphological scan. Conventionally, when you people refer for a thyroid scan, we always do technetium scan and not the iodine scan. Iodine scan is done only in some select conditions. Now, when the scan comes to you from my department, what you have to see is, number one, both the lobes of the thyroid, right and the left lobes. How is the distribution of the iodine inside the thyrocyte molecule? Uniform or not uniform? Apart from that, in some patients, we see pyramidal lobe here in the midline of the thyroid in 20%. This isotope also goes to submandibular gland, parotid gland, and comes through the saliva into the oral cavity. So a thyroid scan contains all these things on its image. So what you will have to see is, have I described all these things or not in the scan? Now, what are the indications? When I was in 80s, there were a host of indications. Today, we have only few. Solitary thyroid nodule, thyrotoxicosis, ectopic thyroid, agenesis of thyroid, and finally, follow-up of thyroid cancer. Each one of them, let us see how we move about. In the solitary thyroid nodule, when you see in a clinic and you find a palpate a nodule like this, what you have here, what are the questions that come to your mind? Is this palpable nodule functioning or not functioning? Why should I know this answer? If it is a functioning nodule, no surgery, only medical management. If it is a non-functioning nodule, it is surgery alone, no medical management. So the first question is beautifully explained by the thyroid scan. Now this ultrasound does not give this information. The second question is, if it is non-functioning nodule, is it benign or malignant? This question cannot be answered by any imaging modality today. It has to be answered only by an FNAC. The third question is, if it is a functioning nodule, is it autonomous or non-autonomous? Why should I know this? An autonomous nodule will convert into toxic nodule. So you should not treat that nodule with thyroxine. A non-autonomous nodule, functioning nodule, can be treated with thyroxine and it suppresses the nodule. So which form of treatment we give, the answer comes from this particular answer to this question. And finally, if non-autonomous nodule, does it respond to thyroxine suppression therapy or not? The scan tells us. Before therapy, 6 months later, you do the scan, the gland gets suppressed. So all the clinical questions that come in the mind are answered by a simple isotope scan. But today, ultrasound has become the first modality and not the scan. Why? Because the scan is not available across all places in the country, whereas ultrasound is present everywhere. That is why ultrasound has been put in the algorithm after the first palpation of the nodule. But however, the scan is very important for answering this question. If you look at the solitary nodule of this gentleman, if the nodule looks like this, no isotope uptake at all, it is called a cold nodule. This contains 30% of the time malignancy. So it has to have an FNAC and surgery. If the nodule has an uptake slightly more than the rest of the thyroid, it is called a functioning nodule or a warm nodule. This nodule does not need FNAC. It does not need surgery. It just needs L-toxin therapy. And finally, the nodule can be like this. Only the nodule is showing isotope uptake, but nothing else in the rest of the thyroid gland. This is called autonomous toxic nodule. So all the three have been classified by a single scan. This autonomous toxic nodule is not treated with thyroxine, treated with radioiodine or surgery. So in thyrotoxicosis, what is the indication? You made a diagnosis clinically that patient is toxic, T3, T4 is raised and TSH is suppressed, we have to differentiate primary from secondary. And secondly, before radioiodine treatment, thyroid scan is performed. So when you have a thyrotoxicosis with a high uptake on the thyroid gland, it is a Graves' disease or a multinodular toxic goiter or a toxic adenoma. If the T3, T4 are raised and on the thyroid scan, you don't see any uptake, then it is called factitious hyperthyroidism, very common in nurses, subacute thyroiditis, ectopic secretion of thyroid hormone, or iodine-induced hyperthyroidism, or deposit form metastasis from thyroid cancer. I'll just show you a few examples here. This particular scan here shows a very high uptake, T3, T4 raised and TSH suppressed. This is classical Graves' disease, high uptake. On the right side, patient was clinically toxic, T3, 4 high, TSH suppressed, but no uptake in the thyroid gland. This is classical subacute thyroiditis. In subacute thyroiditis, there is an edema of the thyrocyte. Because of the edema, the T3, T4 inside the thyroid gland leaks out and comes into the circulation and then suppresses the TSH. This is called secondary thyrotoxicosis. So today we do the scan in these two setting differentiation. Now we have sometimes thyrotoxicosis with struma overi. This is an interesting patient, multinodular goiter with two autonomous toxic nodules here, and there is also concentration of radioiodine in the pelvic area here, and that was a classical struma overi which is seen on the corresponding CT images. So struma overi can produce thyrotoxicosis. So radioiodine scan will help in diagnosis of this particular clinical condition. In thyrotoxicosis factitia, the patient is taking thyroxine to reduce the weight, very common in nurses. So how to diagnose? They come with classical thyrotoxicosis. What picture you will get? There is no uptake in the thyroid gland here, and there is no uptake in the pelvic area of the ovarian. Now, this is a classical thyroxine-induced thyrotoxicosis, and the uptake in the thyroid gland does not occur because the L-troxin contains iodine. It does not allow the radioiodine to go into the thyroid gland. Now, let's say multinodular toxic goiter. Usually, multinodular goiter are not an indication of thyroid scan. But however, in toxic goiter, if I'm trying to treat the patient with radioiodine, or if a surgery is being considered, the surgeon should know which are the toxic nodules in that multinodular goiter. So when he does the surgery, he has to remove all these three. Otherwise, the patient will come back with the recurrent thyrotoxicosis. So to show the autonomous toxic nodules, radioiodine scan is done prior to surgery or radioiodine in multinodular goiter setting. Now, developmental anomalies of the thyroid, there is no modality except the radioiodine scan to diagnose. Look at here, a mass in the posterior 1/3 of the tongue, which you see here. Clinical diagnosis is lingual thyroid. Thyroid scan shows uptake only in that mass, and the thyroid gland is absent. This is a very important information. The lingual thyroid is confirmed, and the surgeon now will decide to take that lingual thyroid and put it in the submandibular area so that patient has a functioning thyroid. The patient presents with a nodule in the midline, very soft and cystic, clinically thyroglossal cyst. You do a thyroid scan, only the cyst is showing the concentration. There is no normal thyroid gland. It's very difficult because if you remove this particular cyst, patient will have no thyroid. Throughout life, they have to take thyroxine. So a very concerted decision has to make in connection with the patient discussion. This is another dual ectopia, a lingual thyroid present here and a thyroglossal cyst. This is a very rare. I've seen only 1 in 40 years, this sort of a dual in one patient alone. And there could be multiple triple ectopia with a thyroid gland, with a thyroid cyst and a lingual thyroid. This is also a rare condition, but all this can be diagnosed by iodine scan. And here is a patient where there is nothing in the left lobe, only the right lobe is there. This is called agenesis of the left lobe. The patient presents with a right lobe nodular goiter because the right lobe is enlarged to compensate for the absence of left lobe, presents as a nodule, and when you scan, you make a agenesis. So developmental anomalies can be diagnosed with the radioiodine scan. Moving on from diagnosis to therapeutic role of radioiodine, we use this in thyrotoxicosis and in thyroid cancer management. In a thyrotoxic patient, we know that the radioiodine uptake is quite high in the thyroid gland. So the first radioactive iodine treatment was given in 1941 by Professor Hertz at Massachusetts General Hospital when he treated Elizabeth D for the thyrotoxicosis with combination of radioiodine 130 and 131. After that, we have moved significantly now. The concept is radioiodine emits gamma and beta rays. The beta rays have therapeutic effect and are used in treatment of thyrotoxicosis and cancer. Thyroid follicle traps the radioiodine, and during its stay in the follicle, the iodine 131 delivers radiation dose through the beta ray, resulting in either total or partial ablation of the cancer cells or the thyrocyte. How is it given? Currently, we give it in the form of a capsule. The BARC provides this every week to us, and this capsule contains a fixed amount of radioiodine, and she just follows the capsule and goes home. That is a simple way of treating for thyrotoxicosis. What is the indication today? Ideal first line of treatment in all patients above 35 to 40 years. Failure of medical management, poor drug compliance, especially in pediatric group, recurrence after surgery of thyrotoxicosis, and surgery is contraindicated due to cardiac or other cause. In all these patients, radioiodine is given as a treatment. The patients attain euthyroid in 6 weeks to 3 months. Due to radiation destruction of the thyrocyte, permanent hypothyroidism occurs in majority of the patients, needing thyroxine replacement lifelong. 15 to 20% of the patients do not respond to one dose. We give a second or third dose at 3 months interval apart. There is no increase in incidence of thyroid cancer over the life of that individual, as we have seen in the last 50 years of usage of radioiodine. Moving on to thyroid cancer, a little bit of on the cancer. Papillary and follicular thyroid cancers are called differentiated thyroid cancers, and their metastatic lesions retain the physiological property of trapping radioiodine, and thus they can be detected on radioiodine scan after total thyroidectomy. The beta rays of the iodine 131 give the therapeutic impact on the thyroid cancer cell. This is the first disease-specific therapy in oncology since 1941. Where is disease-specific? The first patient was treated by Professor Hertz in 1943, Bernard Weinstein at the Massachusetts Institute, and this patient, after 20 years of surgery, developed extensive meds, and they were treated with radioiodine from 1943 to 49. He became completely normal and finally died in 1952 due to anaplastic cancer. Before therapy, he was like this, and after therapy, he went back as the CEO of his company. So it was the first revolution in oncology, very specifically treating metastatic disease. At Raheja Hospital, where we have an endocrine cancer center now, we have made a special radioiodine treatment ward, where this is under the atomic energy supervision, these wards are made. Patient is given this radioactive isotope orally. He is kept in the isolation room for 3 to 4 days to avoid radiation to the others. When the radioiodine is there in the patient's metastasis and the body, the radiation will be coming out. So the relatives will be getting this. So we keep them for 3 or 4 days. After the dose comes down, they are discharged. Treatment is repeated once in 9 months. Overall 20-year survival in thyroid cancer, both papillary and follicular, both in the nodal and lung mets, is 75%. bone metastases do not respond very well to this therapy. So the radioiodine therapy in thyroid cancer starts after total thyroidectomy. If the thyroid is present in the neck, the metastases do not pick up the radioiodine. Everything is picked up by the thyroid tissue in the neck. So total thyroidectomy is mandatory for using radioiodine treatment. What do we do in therapy? Post-op, the surgeon might have left some tissue in the neck. We ablate that with radioiodine. It is called remnant ablation. Second is treatment of the metastatic disease. So the requisites are total thyroidectomy mandatory, confirmed histology of differentiated cancer, TSH level should be 40 microunits when I treat the patient with radioiodine, because high TSH, when it is there, it pushes the radioiodine into the metastatic cancer cell. So TSH dependent radioiodine uptake is there in metastasis. Patient should be off thyroxine for minimum of 3 to 4 weeks, and pregnancy is a contraindication. I just showed few of our examples here. This is a total thyroidectomy done by Dr. Sultan Pradhan. After the surgery, we are finding 2 tissues here. Now you'll wonder why these are left here. Actually, they were nodes. These nodes are not visible to the human eye. Even at surgery, they do not look odd. So sometimes we find that very occult nodal metastasis remaining after total thyroidectomy. And this patient had this tissue and no other disease anywhere. The radioiodine has come through the stomach into the intestine, and that's the bladder here. So I treated this patient with radioiodine. 6 months later, the entire tissue has disappeared and patient has become disease-free. Another patient here, a small residual thyroid tissue. Many surgeons leave because of recurrent laryngeal nerve can get affected when you do a total thyroidectomy, especially if you're not an experienced surgeon. So that tissue which is remaining here, we do not know whether it contains a cancer cell or it's a normal thyrocyte. But we take thyroglobulin, which is a marker for thyroid cancer. If thyroglobulin is high and this tissue is seen, we go and treat with the radioiodine. I treated this patient, but he did not completely respond. Some more small tissue was remaining. I gave a second dose after 9 months. Now he's completely disease-free in the 3rd scan. This is a beautiful scan to show you how radioiodine works, especially in the early phase of the disease. Here is a patient whose chest X-ray is normal, CT is normal, but he had breathless and cough. When we did, and the follicular thyroid cancer after surgery, 4 years. When we did the scan, entire bilateral lung show high radioiodine uptake, suggesting extensive metastasis in the lung, not seen on chest X-ray, not seen on CT. This is called occult pulmonary metastasis, lymphangiectasia, metastatic lymphangiectasia. Now this incidence is 6%. When I had analyzed in Tata Hospital 1,000 patient data, 6% of the patients have this occult pulmonary metastasis. Why should I pick up this? When I treat this particular patient with radioiodine, which I have done here, look at this. Only after 1 treatment, 95% of the disease is completely ablated, has completely disappeared. So when you have no parenchymal nodule on the X-ray or the CT, and only there is a metastasis on iodine scan, response rate is 70 to 80%, total removal of the disease. And when I gave a second therapy, these small nodules which were there, they also disappeared. So occult pulmonary metastasis can be beautifully ablated with radioiodine and given a long 35-year survival to the patient. To get this particular uptake in the lung, we must have a total thyroidectomy. If there is no total thyroidectomy, everything will go here and this will not be detected. That's the reason we insist on total thyroidectomy. So what is the impact of radioiodine over the last 70 years we have been using it? If you look at it, this particular curve will tell you, if I treat the patient only with thyroxine after surgery, this is how the survival will be. Means the death rate will keep on increasing. Whereas if I give radioiodine and thyroxine together, there is a mortality rate is very, very, very low at the end of 40 years. And if you don't give thyroxine also, the metastasis grows very fast. So radioiodine definitely brings down the mortality rate when given post-total thyroidectomy. The cancer death rates after thyroid remnant ablation is beautifully demonstrated here. No ablation, the death rate is quite high by the end of 30. In fact, it starts rising right from the 5th year, keeps on going progressively. Whereas in radioiodine treated patient, up to 30 years, the incidence is much, much less than without radioiodine. So there is no question that radioiodine does significant impact on the survival. Some side effects are there which are very marginal. At least I have not come across a major in the last 40 years. Mild radiation, thyroiditis if there is a residual tissue, mild edema at the site of the where the metastasis is, sialadenitis. Because the radio I showed you in the scan, it goes into parotid and submandibular. Some patient develop sialoid as a dysfunction of the salivary gland. We protect that by giving them sialagogues during the radioiodine treatment, or keep a simple pickle in front of him, the whole saliva comes out. So radioiodine will not stay there. Hemorrhage in a tumor is very rare. Radiation pneumonitis incidence is just around 1%, but we manage with steroids. There is no documented complication in post-radioiodine pregnancy. All my patients whom I have treated 20, 25 years ago are now having lovely children and come back and see every year. No birth defects, no odd complications. There is no increased incidence of second malignancy, which was a worry in the 1970s and 80s, but there is no increased incidence of second malignancies. So radioiodine treatment has stood the test of time for last 70 years. It's my privilege that I've been a part of this journey for the last 40 years. I would like to conclude my talk showing an interesting thing which I read about a few months ago. A thyroid specialist in Boston Medical Center, she made an interesting study that she trained the dogs to sniff the thyroid cancer. So in 34 patients, this Frankie dog diagnosed thyroid cancer in 30 patients only by sniffing. So the sensitivity is 86% and specificity is 89%. Unbelievable scenario. So I started wondering, will I be now going to the clinic with my lovely dog at home if I train him to sniff the thyroid cancer? This is now being used in Canada for prostate cancer and for breast cancer. So the dog seems to be going to play a major role as we come in the years in the clinical oncology. This is a cat which had a metastatic thyroid cancer on the top, treated with radioiodine, and now after the therapy, the cat is back to its original self. So that's the impact of radioiodine. Thank you. It was wonderful being with you all.
Thank you very much, sir. Very simple and lucid presentation. Sir, I have one question in the question box. Sir, a solitary nodule which comes follicular changes on FNAC which cannot differentiate between benign or malignant follicular carcinoma. In this situation, should we do thyroid technetium scan or directly proceed for surgery?
No, you should do a scan, and if the scan shows the nodule to be functioning, that means on the follicular cells are coming from a functioning thyroid. You don't need a surgery.
Okay. I think the answer you have already given, second half of the question. How can we know whether the nodule is functional or non-functional? Okay. That was only one question in the question box. Are there any questions from the panelists?
Yes, such no. Anil, there is no any question.
Okay. Yeah.
Yeah. Thank you so much.
Thank you.
Thank you so much, Dr. B.A. Krishna, for giving a wonderful information.
Dr.
Yes.
Usha, Dr.
Yeah.
Usha, one more question has come.
Okay.
Does levothyroxine work in treatment?
Yes, if you have a functioning thyroid and nodule, or then you want to try thyroxine when you treat them, about 30 to 40% of them get suppressed. The problem only thing is the moment you stop the
Vicky,
thyroxine,
aji Vicky che beta. Vicky finika. Vicky.
Once you stop the thyroxine, the nodule will come back. So whether he has to take lifelong thyroxine is an issue that comes up.
Okay, thank you, sir. Thank you very much.
Thank you. It was a pleasure.
I'll just repeat your side. It was wonderful being with you today morning.
Thank you. Thank you.
Yeah, over to Dr. Usha.
Thank you, Dr. B.A. Krishna, for giving wonderful information about the thyroid disorder in nuclear medicine. Now the next speaker is Dr. Diksha Kriplani. I request Sarita Devi, IMA CGP member, to introduce the speaker.
Dr. Diksha Kriplani. She is a pathologist currently working as a blood bank officer at Bridge Candy Hospital, Mumbai. She has done her MBBS and MD pathology from Jawaharlal Nehru Medical College, Wardha, Maharashtra. She then did her fellowship in hemato-oncology and fellowship in clinical hematology from Bridge Candy Hospital, Mumbai. She has worked as a tutor in Jawaharlal Nehru Medical College, Wardha, and as a clinical associate in pathology at Jaslok Hospital, Mumbai. She has presented many papers in various conferences and won many prizes. She has done many poster presentations and won first prize at 56th Epicon 2010 and third prize in PrimeCon 2012. She has done numerous publications and research work. Today she will speak on oncology update. Over to you, madam.
Good morning, everyone. Am I audible to everyone?
Yes,
Yes,
madam.
yes, yes.
Okay, thank you very much for the introduction, but the introduction wasn't completely correct. I'm not a blood bank officer at Breach Candy Hospital. I am an associate hematologist and hemato-oncologist. I would not be speaking on oncology updates if I was a blood bank officer. I have done my fellowship in hematology and hemato-oncology, which is why I'm in front of you here today, speaking on today. The topic that I will be covering is immune thrombocytopenic purpura. And this is one topic which is, I feel I'm at the right platform talking to the IMA group of members here in Mumbai. First of all, let me just say that it is an honor to be able to speak to everyone today. I wish it was a real face-to-face live conference, the CME, so I could meet with everyone, but times are such that we will adapt to changes. Immune thrombocytopenia is something all of you have seen more than I do. After you have seen those patients, you pass them on to me. But all of us think that this is a relatively easier disease to treat because we all start the patient on steroids and most of us get a very good response. So we feel that this is is not a disease of concern. But let me tell you, ITP is a very, very heterogeneous disease. In fact, the concept of one size fits all does not apply to ITP at all. We get lucky when our steroid treatment shows response, but that is not always the case. In fact, it is not always the case 40% of the times. To discuss such cases, I would like to take this in a case-based approach. My first patient today, or these are all real-life cases that we have seen. My first case is a Bengali lady. She's a 42-year-old female and she was posted for a surgery, a laparoscopic cholecystectomy. Nothing of concern. Now, this is something that they say is nothing of concern. So as a preoperative workup, her CBC was done and her platelet count was less than 1 lakh, something which is required by all surgeons before they even touch the patient. So the platelet count of this one was 72,000. And so she was referred to a hematologist for her platelet workup. Reference to a hematologist is another very common, it's a very unfortunate scenario that it's not always done. But since this one needed to go for surgery, she had to have her platelet corrected before she was opened. All her other parameters as her preoperative workup were normal. So she was sent to a hematologist for checking out what was wrong with her platelet counts. Now, the most powerful tool of a hematologist is or should be that he is able to see what is actually happening to the blood under a microscope. So that is exactly what we did in our lab. And we saw that this is what her peripheral smear looked like. Now, this is what we call as large platelets. As you can see, I mean, not all of you are pathologists or see slides every day, but this is evident to any person who has not even seen a platelet before, that these are large platelets. They're almost the size of an RBC, which are just next to it. So these large platelets are what is what we saw on the peripheral smear. And so we termed this patient to be a case of pseudo-thrombocytopenia. Now, this is a very physiological phenomenon, especially in Northeastern people. Now, this lady was a Bengali and she had these large platelets. She, in fact, had 2 deliveries and 1 cesarean section in the past in which she had not bled. So that was a very supportive history in our favor, that she's gone through surgeries before in the past without any complications. And she has never had, she was not on any incriminating drugs as well. So seeing such platelets, we labeled her as a case of pseudothrombocytopenia and gave her a certificate of fitness to go for surgery, and explained to her what large platelets will be and how to go about her CBC from here on in the future. We told her that every time you, God forbid, if you need to go through a surgery again, or if you are in an emergency case and your CBC is done and they see a platelet count which might not appear normal, ask for a manual count, ask for further tests, and ask for a hematologist to go through your slide to approve that you are a case of pseudothrombocytopenia, in which the platelets, they when the blood is run through a machine, the machine is trained to read the cells according to the size of the cells. Now, in such cases, the size of the platelets are almost as big as the WBCs and the RBCs. And so the platelets are not being read as platelets and they're being read as other cells. And so the count of platelet being low is actually a false count. So this is what happened in this patient. Now, I will come to our topic of today, which is ITP. Now, what is ITP? Primary ITP, as you all know, is a problem of the immune system. Now, this immune system, when it gets too moved, it causes one of the problems, which is ITP. What happens in this is, if this is a platelet, it has 2 kinds of receptors against which antibodies can develop. One is this GP2B3A, and it starts to develop antibodies against it. It's a body's own immune system's fault. It's nothing that the patient is doing to himself or herself. And the other is GP1B9 receptor. These are the 2 common receptors on a platelet that usually catch antibodies, which are autoantibodies. And when these platelets run through the spleen, now spleen is like the army base of a body, where it is hosting all these lymphocytes that are just waiting to kill any cell which is not supposed to be in the body. So basically, it is the phagocytosis center of the body. So a spleen hosts lymphocytes which read these abnormal antibodies and destroys its carrier, which are the platelets, which are actually innocent. Which is why in primary ITP, the antibodies attaching to the platelets cause the damage of the platelets. Of course, there are a lot of secondary causes also that can cause an ITP-like picture or ITP. Some of them are very common case scenarios that we see in our day-to-day practice. Especially drug-induced thrombocytopenias are very common. In today's day, dengue is the in thing. It is most in vogue, and so we are seeing a lot of thrombocytopenia associated with dengue. To which point I would like to point out that even today I have a patient who is at a platelet count of 11,000 with dengue, who is not bleeding. And so we've still held on to platelet transfusions because this is dengue associated thrombocytopenia, and it is not dangerous unless it is falling less than 10,000 or the patient starts bleeding. These are some of the very common drugs that all of you are using on day-to-day practice. Have a good look at these. These are the common drugs that cause thrombocytopenia. And you might not even realize that the thrombocytopenia, which evidently has started once you have started the drug, is the etiology behind this. The problem with ITP is that there is no diagnostic test that you can just do and say that yes, this is ITP. So basically, there is no gold standard test in as a diagnostic test for ITP. Like dengue, I could do a dengue antibody antigen, or I could and just label the patient as dengue. But with ITP, it is mostly a diagnosis of exclusion. When you remove all the secondary causes, when you rule out things like pseudothrombocytopenia, when you rule out other bone marrow issues that could happen with the patient and cause thrombocytopenia, when you rule out everything else as the cause of thrombocytopenia, you can go in the direction of ITP. A major factor, a major test that we at Rich Candy Hospital have is called the immature platelet fraction. It is a very simple test. It is a part of our CBC itself, but it is not what normally is included in all CBCs all across the labs in Bombay. Immature platelet fraction basically tells us about these baby platelets. Now, what are these baby platelets and why are they important and why do they help us in ITP? Now, these baby platelets come in picture when the demand for platelets is very high. So basically, whenever platelets are being destroyed for whatever cause might be, when the demand for platelets is too much on the body because there's more destruction, so the body needs to produce more and more. So in an attempt to cope up with the requirement, with the demand, the bone marrow starts to throw out the immature platelets as well. Now, these immature platelets have not reached their maturity, but they have acquired their functioning. So these small platelets, these baby platelets, they know how to do their job, but they're just not mature enough. So when these immature platelets are seen in the CBC, we know that nothing has to be worried from platelet point of view, and the patient will not bleed. So typically, in a case of peripheral destruction of platelets, like in ITP, the immature platelet fraction is very high. And when we see this, we are more certain that we are heading to the diagnosis of ITP. In a case when the thrombocytopenia is because of a bone marrow problem, like aplastic anemia or a bone marrow suppression because of radiotherapy or any other cause of bone marrow suppression, the IPF will be low or towards the lower side of normal. The normal count of IPF, the range is 0.7 to 7. In ITP, we see IPF ranges from above 15 to 20. Even on the slide, we can see those immature platelets as I've shown in the peripheral smear previously. The other thing that we do to confirm the diagnosis of ITP is a bone marrow. Now, this is another tool that a hematologist has, and this is what an ITP picture on a bone marrow looks like. These are the megakaryocytes that we see in one field. There are 3 in fact, there are 4 or 5. I have not marked out all of them. But in such an increase in megakaryocytes in each field means the megakaryocytes, which is a factory of the platelets, they are overworking. They have multiplied to keep up with the demand of the peripheral destruction. And so even the megakaryocytes are seen more in number and immature forms are seen. So these non-budding forms on the bone marrow and increase in the megakaryocytes is a typical picture of ITP. And so to this patient, after having done all of this and basically ruling out all the other causes of thrombocytopenia, we labeled him as a case of ITP. Now let's move on to the next case. Now this is a 33-year-old female, and she complained of new petechial rashes all over her body. And she also, for the past couple of months, complained of heavier than usual menstrual bleeding. So when she reached us and we saw her in our OPD, we did a CBC, of course, and we saw that a hemoglobin count was quite okay. So that means that the bleeding was not very evident. The bleeding was not very heavy, but her platelet count was alarming. As I told you, a platelet count less than 10,000 is alarming, and hers was 8,000 at that point of view. At that point of time, her IPF at that time was 15. So we knew that there is some cause of peripheral destruction of platelets, which is why the platelets have dropped to 8,000, and which is why she is having heavier than usual bleeding and these petechial rashes. So we examined her. We examined her for her spleen, for her lymph nodes, to rule out all the other causes of possible destruction of platelets, to rule out the secondary causes of ITP. She had no lymph nodes. She had no lymphadenopathy. She had no organomegaly. Her peripheral smear did not show any schistocytes or any platelet clumping. So we knew that there is some problem with the platelets itself. On examination of her oral cavity, we saw that she had a blood blister in her mouth. Now, I looked for a lot. There is data, but I just could not find the article today. But the evidence of blood blisters it's quite a tongue twister. Blood blisters. The presence of blood blisters is quite an alarming sign, a symptom, when it does have high incidence of intracranial hemorrhages as well. And at a platelet count of less than 10,000, the patient is very prone. The main danger is of her bleeding intracranially. So I would like to ask all of you, if this patient would have come to you, which is very likely to happen, how would you approach this case? I'm not sure if you can reply to me, but if you have some comments in the chat section, I would like to see what the general trend is. I have conducted this survey amongst another group of doctors as well, and I know what the majority of doctors do. I'm giving you a certain set of options. Please choose one and please post it in the chat box. Would you give her platelet transfusions at the fear of intracranial hemorrhage at a platelet count of 8,000? Or would you start her with prednisolone 1 milligram per kg? Or you choose the other steroid, dexamethasone, at 40 milligrams for 4 days? Or would you start her with dexamethasone and admit her for IVIG simultaneously? If someone could just tell me, or I'll just open the chat box myself and see what most doctors are choosing. I am getting mixed opinions about A and C and D. Some are also saying B now. It's quite a mixed approach that everybody has. Dr. Mahmood Merchant has posted that D is the answer. So I see that there are a lot of mixed responses. So see, these are all four very possible options that you have in such a patient when platelet count is 8,000 and you know that she is very likely to bleed intracranially. But option A, giving platelet transfusions, which is what I have seen in my surveys conducted elsewhere, is most commonly done with such patients. They admit them for platelet transfusions and start platelets immediately. But believe me, this is not the answer to this approach. As Dr. Mahmood Merchant has already posted, the answer to this situation is D. The patient is not actively bleeding at that point. Giving platelets to a patient, as we have understood, is developing antibodies to platelets and destroying the platelets in the peripheral smear, whether it's her own platelets or whether it is a platelets that you will transfuse from outside. The patient is going to destroy them very soon. So giving platelet transfusions and exposing her to the risk of a transfusion, especially with TRALI, especially in these dengue patients that we are seeing, the same situation applies to dengue patients as well. Giving them platelet transfusions when they are not actively bleeding is not the answer to the problem in hand. The answer, as Dr. Merchant said, is option D. Now, IVIG is the next fastest option of increasing the platelet counts. It shows response within 24 hours. So that is what we should do primarily, and start the patient on dexamethasone. Now, between dexamethasone and prednisolone, it is a very close call, but there are a lot of researchers which say that dexamethasone shows faster and more deeper responses with platelets, with improving platelet counts than prednisolone, but both options are equally good. So in this patient, since we need a faster response to increase the platelet count so that she is out of that critical range, we start her on dexamethasone and IVIG simultaneously. Dexamethasone is expected to show its effect within 24 to 72 hours, and IVIG will show effect within 24 hours. So within that same day, we are starting to see an improvement on platelet count. So in this patient, what we did, she came to us in our OPD, and and we started her on dexamethasone while she did her arrangements for admission for IVIG. So what are the red flags that you see when you see a patient of low platelet count? It's not every thrombocytopenia case that you should be scared of. Not every low platelet count patient will bleed. So if the patient has had prior history of bleeding, then yes, there are chances that the patient will bleed at a lower platelet count, even if it's not less than 10,000. But if the patient platelet count is less than 10,000, like in our patient, there are definite chances of bleeding. I mean, there are high chances of bleeding, not definite. And in cases when patients have more comorbidities and they are on some anticoagulants or antiplatelets, or if they have any bleeding disorders diagnosed earlier, chances of bleeding are higher. So when you see such scenarios in a patient, then you might consider a quick action. In our patient, none of these had happened. Prior history of bleeding, yes, she had heavier bleeding, but we don't know for sure whether how significant that was. The beauty of ITP and its treatment is that most of ITP treatment is done on OPD basis, except for those rare cases like this case when you have to admit the patient for IVIG. In fact, even IVIG is it can be done on OPD basis, but it's safer to do it on IPD basis. At this point, I would like to tell you that beautiful concept of a hematology lab that we have at Breach Candy Hospital. In Breach Candy Hospital, we have an OPD setup where we can manage ITP patients without admission as well, because we have what not any other hospital in Bombay has. We have is a lab plus a clinical center together. So this is the entrance of our hematology unit, where we have a hematology OPD, and it is supported on the same floor by the hematology lab, as you can see on the left end of the photo. So when a patient, like exactly this patient, when she came to us in our OPD. Immediately we ran a CVC, and within 5 minutes we had the CVC report in hand, and we knew that this is a critical case and we need to take immediate action. This is our daycare. Immediately we admitted her, we put her in our daycare, and we gave her the first dose of IVIG and dexamethasone. Meanwhile, her relatives went ahead and started doing the procedures for admission, because everybody feels safe admitted in the hospital at a platelet count of 8,000. But if suppose we do have such cases where a patient has come with bleeding and low platelet counts, we are also supported well by a blood bank, which is on the same floor. So the units, the blood products, components, everything is available to us on the same floor, and the patient doesn't have to run around anywhere. And it's a very concise, comprehensive clinic that we have at Breach Candy. And I'm very proud to be a part of this kind of a setup. So now let us see what kind of an approach is ideal for a case of ITP. So when a case of ITP comes to you in your OPD, or you attend to a patient whom you suspect to have ITP, the first thing that you see is, as we already discussed, the platelet count and whether there are any other causes of bleeding, like antiplatelet drugs, or any bleeding disorders that the patient has, or any other drugs that the patient is on which can cause bleeding, or any liver disease, which is also which just adds fuel to the fire. In our patient, we saw that the platelet count is low, but there were no other bleeding risks. And the patient, whether the patient is bleeding or not bleeding actively at that point. Well, let's assume that our patient was bleeding. The next thing that we have to see is whether this is a critical or a severe bleed. Now, critical bleed would have been an intracranial hemorrhage, or bleeding profusely into any other cavity of the body. Or a severe bleed would be when the bleeding has caused a drop in platelet count, a drop in hemoglobin to more than 2 grams per deciliter. If such severe bleeding is happening, then both of these are very critical to deal with at that point. And at that point, what you should, if patient is actively critically bleeding, then yes, platelet transfusion is a quick solution to the emergency in hand. But if not, then as I discussed, IVIG and dexamethasone are the next two best options that are actually show long-term benefits and will help the patient increase in a steady way with the platelet counts. So, and if the bleeding is not very active, suppose the patient has come with bruises and low platelet count, which is not severe bleeding at all, then IVIG and DEXA is definitely the treatment of choice to begin with. But platelet transfusions have to be avoided at all costs. If the patient is not bleeding but has a low platelet count, then what you should do is see what kind of platelet count is actually low platelet count. So what kind of platelet count is actually a low platelet count? If the platelet count is between, if it's, sorry, that's a wrong symbol there. If the platelet count is between 20 to 30,000, then you continue with IVIG and DEXA. But if the platelet count is more than 30,000, believe me, that is nothing to worry about. Even though today, when we see platelet counts with dengue of 30-40,000, we get scared. We want to start the patient on platelet transfusion. Nothing to worry when the count is more than 30,000. Just observe, do regular CBCs, and monitor the patient for any signs of bleeding. So this is a comprehensive approach to thrombocytopenia, and what are the red flags that you should look for, and how to begin with first line therapies for ITP. So in case 2, we started our patient with IVIG. We gave it to her for 4 days, and dexamethasone. And she showed improvement in her platelet count from the next day onwards, and she is doing well since then. This is the third patient. He's a 24-year-old male. He was diagnosed as an ITP case as a child, and he has had it since childhood. The first line therapies that were given to him, dexamethasone, IVIG, did not show response to him. So since childhood, he has been a case of ITP. So what do we do when, in such cases, when our first line therapies fail? What are our backup options? Now, in ITP, we have 3 major weapons to fight a relapse, not a relapse, but a poor response to first-line therapies. The first weapon is a splenectomy. I'll talk about this in a minute. The second is rituximab, and the third TPORAs. Now, splenectomy, which is our first weapon, I have put it first because it is actually our first, most important, and it's like the penicillin of the ITP world. It's the most basic weapon that we have, which basically sorts the problem for life. So once a spleen is removed, because we saw what the spleen is doing, these platelets were attached with autoantibodies, which the body is attaching onto. So when these platelets run through the spleen identifies our own platelet as foreign because of these antibodies attached to it and destroy it. So why not just remove the spleen? Now, what this does is it just settles the problem at its base, and it gives us a very, very long response and a very durable response. In fact, splenectomy is one of the treatment options which is shown to have the most long-lasting response in almost 80% of patients, and 80% is also the highest that is achieved in the second-line options that we have for ITP. Once the spleen is out, there is no need for monitoring the patient from there on, not as closely as you would do with the other options, once in 6 months. And if every time the count is normal, which mostly it will be, then the patient is free to go. He doesn't have to worry about anything. He doesn't have to take any more medications except for penicillin, which will be a prophylactic drug that he or she will be taking for life. And the best part is that splenectomy is a much cheaper option than the other 2 options that we have available, rituximab and TPORAs. In a patient of ITP, if the patient is coming to you with a platelet count of 10,000, 20,000, now how do you prep him for splenectomy? Of course, for splenectomy, you need the platelet count to come up to at least 50,000. So at that point, you might consider giving him IVIGs. IVIGs is a quick response. It most likely will increase the platelet count within the same day. It will start working in 24 hours. You build him up for the platelet counts, and you give him the vaccinations for all the encapsulated organisms at least 2 weeks prior to whenever you plan to do the splenectomy. And with these preparations in mind, we have seen in our patients who cannot afford the second lines, or who are just nothing else has worked with them, and we've just done a splenectomy and seen beautiful responses with splenectomies. The problem with splenectomies is that they are always prone to infections, and they have to be on prophylactic penicillin for life, and they're also prone to thromboembolic events. We had a very young boy who had failed all lines of therapies. Everything was done for him. He spent lakhs of rupees, but nothing worked for him. But he was only 8 years old, and he was very reluctant to go ahead with splenectomy because his whole life was ahead of him, and he didn't want to go ahead with a major organ which is fighting infections for him. But last year we did splenectomy for him, and till date he's shown very good responses. Of course, he is on penicillin. He's not very compatible with he's not very compliant with penicillin, but so far we've not had any problems with him. The next weapon that we have is rituximab. Now, rituximab is a monoclonal antibody. We have to give it for at least 4 doses of rituximab have to be given as a first course of therapy. And it shows good response. It shows a very durable response. But the problem is that in most patients, the response with rituximab might not last very long, like unlike in splenectomy, where the responses last for almost a lifetime. So with rituximab, you might have to give booster doses almost every year or every 6 months, depending on what kind of response the patient shows. Before giving rituximab, we have to screen the patient for hepatitis markers, because rituximab can reactivate the hepatitis B infections. And rituximab, the other major side effect that we see with rituximab is a lot of our patients have neutropenias. They might not be clinically significant. They might not bring the patient's count down to ANC less than 1000, but they do cause neutropenia and puts them at a risk of infections. But the main problem with rituximab today is that it interferes with immunization. And of course, COVID immunization is going on strong everywhere. A lot of our patients who were opting for rituximab because it was a one-time thing and it is a better response with rituximab have now opted to the second option that I will come to in a minute. Because they wanted to go ahead with COVID immunization. Now, rituximab interferes with all kinds of immunization. In fact, if you have a splenectomy and rituximab planned together, then you might want to hold on to splenectomy for at least a few months, at least 6 months till before you consider the patient for splenectomy, because rituximab will interfere with your immunizations for splenectomy as well. But today, the more practical problem is COVID immunization. That brings me to the third option for today, this is what my focus is for today, is TPO-ROs. Now, TPO is a hormone which is produced by the liver, and it stimulates the megakaryocytes in the bone marrow to produce more and more platelets. Now, TPO-ROs are like TPO mimetics. Basically, they do the same job as the TPO does. And so this is what acts at the bone marrow level, unlike rituximab, which is acting on the peripheral level, and a splenectomy, which again is acting on the peripheral level. The TPO-ROs act at the bone marrow level. They go right into the factory and try and solve the problem, which is less platelets. So they go at the baseline and try and create more platelets to solve the problem. And a lot of patients who have not responded to the first line therapy, in fact, practically speaking, today are second line approach to them is to start them on one of the TPO-ROs that is available. Of course, TPO-ROs, they take at least 2 weeks, in fact, even 3 weeks to show complete response. You have to maintain your patient by other methods if the patient is at a critical stage of bleeding. So the American Society of Hematology has recently posted guidelines on ITP as to how to approach these second line therapies. And well, this is a very comprehensive table, and I'll just take you through the brief of it. The main point that they have is that you have to see what the patient wants. So this is what the patient wants. If the patient does not want to go for a surgery, forget splenectomy and just look at either rituximab or TPO-ROs. And based on the side effects and the advantages of both, you just have to weigh the options, because there are no comparative studies between rituximab and TPO-ROs to show which is better. So basically, both are equally good, and you have to go ahead with what the patient wants. Now, in our case, this patient that we are talking about, our patient was a young patient and he was very reluctant for surgery. So splenectomy was out for him. So we started him on one of the TPO-ROs called Eltrambopac by the name Revolade. Revolade is from Novartis. It's the first TPO-RO that was available to us in India. And 2 months later, 2 months is good enough time that we have given him given Revolade to act on him and show good response. But unfortunately, in this case, we have seen that this patient has not shown a great response, and his counts continue to be between 10,000 and 60,000 after 2 months after starting Revolade. So now, do we label this patient as a failure to Eltrambopac? Before doing that, because it's a major decision whether we discontinue or we change his line of therapy, we did a very, very deep history taking of this patient as to what kind of compliance this patient has to Eltrambopac. So Eltrambopac has something called as Eltrambopac diet, a Revolade diet that the patient has to follow. So it has to be taken, it is a OD dose to be taken every day on a fasting stomach at least 2 hours before and after the medication. Now, it might sound very simple for me to say, but as all of you know, not everybody can be 4-hour fasting either in the morning or whenever through the day to take one tablet. And even then, you have to be you have to avoid dairy for the time around your Revolade. And my patient was not doing that at all. He was dunking down his Revolade every day with an Oreo milkshake. Now, you might argue with me as to how much milk is in a milkshake, but it was significant enough for his Revolade to not show action. So now in this patient, we understood that he was a young patient. He was not understanding the severity of the importance of this Revolade diet, and he was being very poorly compliant with the Revolade diet. So we shifted him to another TPO-RO. And to understand that, let me tell you about the 3 TPO-ROs that we have available. Eltrombopag is Revolade, as I've already told you about. The next one, which has very recently become available in India, of course, in US it was available for a long time, and it has been approved for a very long time. But Intas has brought this to India by the name Romi. I think just a year and a half back, very recent. Romiplostim is a subcutaneous injection to be taken once a week. Now that solves the problem of my patient, and it does not have to follow any diet. It is irrespective of food, and it is not to be taken every day. So my patient, who was young, who was very poorly compliant with a discipline of a diet for a tablet, Romiplostim was the solution to him. Between Romiplostim and Eltrombopag, once a week dose suited him better. Avotrombopag is another TPO-RO which is not available in India, so we won't discuss about it in detail. But let's see whether we have a comparison between these 3 superheroes that we have today as second-line options for our ITP patients. Now, Eltrombopag is shown to shows response in 79% of patients who have failed first-line therapy, whereas Romiplostim will show response in 91% of patients. So that way, Romiplostim is even a stronger drug when it comes to second-line therapies. Well, Avotrombopag is 93%, but since it's not available in India, we should not get tempted by this number today. And 60% of these patients have a long-lasting response. So that is a good this thing. The problem with TPO-ROs is they have to take it for life. It's not like rituximab that you take one course of rituximab, 4 doses, and you finish it, and then maybe take a booster dose once in 6 months later if needed. This has to go on for life. So 60% of the patients of Eltrombopag respond, but some of them stop showing response in the long run. With Romiplostim, it's a similar but a slightly better figure of 61%, and a slightly better picture with Avotrombopag. The problem is what we have to look at is the side effects. Revolade or Eltrombopag, it causes hepatotoxicity. So a lot of our patients who already have cirrhosis of liver, very, very common problem that we see, or have other hepatotoxic drugs ongoing with them, or in fact even cataracts. Patients who have had cataracts should avoid Revolade and go towards Romiplostim, because both of these side effects are seen with Revolade are not in Romiplostim. With Romiplostim and Revolade both, the risk of progression to progression of ITP to MDS or AML is high. It causes the bone marrow to produce more and more reticulin and blasts. And so in patients of MDS, if you are MDS patients also present with thrombocytopenia, you have to really, really weigh your options of the benefit that you will have and the side effects that you will have with one of the TPO-ROs if you want to start that for thrombocytopenia in MDS. In fact, it's mostly avoided unless there is nothing else that is working for the patient. They also put the patient at a high risk of thrombotic events. So we had a patient of RCC. RCC, as you all know, is a very thrombogenic cancer, and her platelet count post chemotherapy would just not rise, and her chemotherapy would get delayed because of her platelet count. And we wanted to start her on one of the TPO-ROs, but because of this thrombotic events, it was a tough decision, but we did give her a course. Thrombotic events are not very common, but they do put the patient at an increased risk of thrombotic events. And in such times, we just have to weigh the benefits versus the side effects before we go ahead with a treatment decision. With Avotrombopag, I don't have any clinical experience. In fact, nobody has a lot of clinical experience today because it is a relatively new drug approved by the US FDA. So, but thrombotic events are also seen with Avotrombopag. Now that we know that we have these second line options, we also have to know when not to give them. If a patient who has already had thrombotic events in the past, obviously you will not want to put him on another drug which will add to the risk of thrombogenic events. So if the a prior thrombotic event history is TPO is to be avoided. With APLA, antiphospholipid antibody syndromes, and lupus, of course, again with the same concept, TPO drugs are to be avoided. And in secondary ITPs, now the beauty of secondary ITP is it is secondary to some problem, a problem that if you remove the ITP will be solved. So there is no point of starting a Revolade if it's a drug-induced thrombocytopenia. You will just remove the drug and the thrombocytopenia will solve itself. So this is when you should know you should not be starting the patient on TPO ROs. Today we have a lot of other therapies available as a treatment option, but we so far have not found the need that to start any of these. In fact, the study with danazol and other immunosuppressive therapies like mycophenolate mofetil and azathioprine, the data is not very supportive in their favor. So, but there are other treatment options available. So if a patient with ITP, there was a time when he would bubble wrap himself because he's prone to bleeding at any point. We have come a long way from that situation. We have good first line and very, very good second line options available today. A patient of ITP does not need to be a bubble wrap boy anymore. We are seeing very good responses with second line ITP therapies as well. I would like to thank IMA for giving me this opportunity to speak today in front of so many doctors of Bombay. It's an honor. Thank you.
Thank you, Dr. Deepsha Kriplani. There is a question.
Sure.
Yeah, ma'am. It is if ITP improves with treatment.
Yes.
Is it possible that eventually patient needs no treatment?
In childhood ITPs, we have, it is quite often seen that if the patient responds, he will not probably need any treatment again for life in the future. But with adult ITPs, if you have given rituximab, if you've done splenectomy, yes, there are very high chances that you might not need any other therapy for ITP per se, and the patient might have a long durable response for life. But with other therapies like Revolade and rituximab or romiplostins, you might rituximab and romiplostim has to go on for life, but rituximab might show a failure at some point in the future, at which point you can consider giving a second dose of Revolade, like a booster dose.
Okay, now there is one more question. In
Sure.
a splenectomized patient,
yes,
is the vaccination used for prevention of pneumonia?
We have pneumococcal vaccines very commonly available. We have Pneumovac and a lot of other brands. We generally cover the patient with the 3 encapsulated organisms, that is pneumonia, H. influenzae, and meningitis. At least 2 weeks prior to planning a splenectomy.
How often should it be given?
Of course, we give it once in 5 years. But some doctors are suggesting booster pneumovac or pneumococcal vaccine every year, especially in these COVID times. I have seen a lot of them giving booster doses to avoid pneumococcal infections.
And what is the drug and the dose for the prevention of malaria?
After splenectomy?
Yeah, after splenectomy.
That you should be telling me, or you're all general practitioners. How to treat malaria is your area, not mine. If my splenectomy patient gets malaria, I'm going to send him to you.
Now the last question.
Yes.
Are platelets produced after TPO-RA in ITP? And
that is the job of the TPO-RO. That's what I said. It works at the bone marrow level. TPO basically is thrombopoietin. It's like, if you know erythropoietin, the same parallel version of platelets is thrombopoietin. It's a hormone which stimulates the megakaryocytes. So it will go to the bone marrow level, stimulate the megakaryocytes, and the megakaryocytes will produce more and more platelets. That is the job of a TPO-RA, receptor agonist.
Okay, thank you so much, Dr. Deepsha Kriplani, for giving a wonderful information about the platelets in oncology.
Thank you very much.
Now the next speaker is Dr. Shobna Bhatia. She is a gastroenterologist, and to introduce the speaker, our IMA CGP member, Dr. Komal Chatania, will introduce her. Dr. Komal Chatania, please.
Hi. Dr. Shobna Bhatia is a consultant in the Department of Gastroenterology at Sir H.N. Reliance Foundation Hospital and Research Center. She is a former professor of gastroenterology at Sheikh GS Medical College and KEM Hospital. After completing her MD, she did her DNB in gastroenterology at KEM Hospital, Mumbai. She underwent an advanced fellowship training in esophageal motility and pH at Philadelphia under one of the earliest innovators in motility. She was the recipient of Unichem Lectureship in Gastroenterology and Indian Society of Gastroenterology Olympus Mitra Award for Endoscopy. She has also been honored with the NBE Excellence Award by the Honorable Vice President of India, Sri Venkaiah Naidu. She has vast experience in the management of functional gastrointestinal diseases, solid-state manometry with impedance, pH metry, and breath testing. She has authored many important papers and book chapters on esophageal motility, GERD, IBS, esophageal diseases, and dyspepsia. She is the chairperson for the task force on dyspepsia and a core group member for the task force on irritable bowel syndrome. She is on the editorial board of the Indian Journal of Gastroenterology. Today she will speak on heartburn. Is it always gastroesophageal reflux? Over to you, ma'am.
Good morning, everybody. Can you all see me, hear me? Is that okay? Hello? 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 Can you all hear me?
Yes, madam.
Yes, ma'am.
Yes, madam.
Okay. Can you see me? I'm just putting up my slides now. So good morning, everybody. And I must thank the IMA for giving me this opportunity. This is a subject that's so close to my heart that I always like to talk about it. And just a few moments before I started, while I was just winding up, I got a call saying that I could speak for a little extra time. So I have pushed in a little more slides, and I hope I don't go over time. But I guess this is a topic that's so important that it's always important. So let me just start with talking a little about what is reflux and what is heartburn. So reflux is the passage of gastric contents into the esophagus, and it occurs in everybody. So when I say occurs in everybody, all of us have had at least one episode of reflux in our lifetime, maybe after eating heavy food on a Sunday afternoon or at a wedding. And this feels like severe burning sensation in the chest. And sometimes there's food that comes up. So the symptoms of GERD or gastroesophageal reflux can be divided into two types. The typical one, which is heartburn, that we're going to talk about today, and acid regurgitation. Now, if any of you or me see a patient who has typical heartburn, that means food coming up into the esophagus and burning, our first and final diagnosis is gastroesophageal reflux. And I think in more than 80% of the cases, we are all going to be right. So all of us would then give the patient a proton pump inhibitor, maybe add a little antacid, and in 80% of the patients, the patient would not come back. But there are a few who keep coming back. Some of them we would label as PPI resistant GERD, which means that we are still saying that they have reflux, but that they are resistant to our PPI that we are giving. Sometimes there can be problems. So let's see what causes the symptoms. So when reflux, that is acid, enters the esophagus, there is irritation of the esophagus. There is neural stimulation, and the symptoms are actually generated in the brain or perceived in the brain. Now, when we talk of acid production, remember that except for Zollinger-Ellison syndrome, acid is similar in almost all patients and normals. So acid production is not high. It is just that the acid reaches the esophagus and manages to cause symptoms there. The acid has to cross the gastroesophageal sphincter here, also called as the esophagogastric junction. And whenever this acid occurs, there is some saliva that is produced, and we swallow that saliva to neutralize the acid. The esophagus contracts and pushes that acid down so that the acid is cleared from the esophagus and there is then no active damage that is caused. When this occurs recurrently is when the damage occurs. In some patients, gastric emptying is abnormal, and that we see in patients who have a lot of gas bloat or patients who have, say, diabetes. They're likely to have delayed gastric emptying, and then they keep having reflux, and instead of treating them for the delayed gastric emptying, we think that they have reflux, and this could be a problem with patients with delayed gastric emptying. So if we look at gastroesophageal reflux, there are two types, or you can put them into two severities. One is mild to moderate, where the sphincter closure is abnormal, and there is a phenomenon called as transient LES relaxation. Whenever we have a full meal, the fundus of the stomach relaxes, and the LES relaxes sometimes even without us swallowing. And that time a small amount of reflux occurs. And that happens in normals also. But when there is severe reflux, just a moment. But when there is severe reflux, the pressure is actually strained and there is the development of a hiatal hernia. Now, whenever the fundic pressure is high, the gastric contents get into the hiatus hernia, get into the esophagus, and here there is more of a structural abnormality as compared to mild to moderate reflux, where there is more of a functional abnormality. So let's take some few quick cases. This is a 25-year-old college student. Just before his exams, he starts getting this heartburn. He says that whenever he takes antacids or some PPI, he's fine. And after his exams got over, he's absolutely fine. So this is something that happens in many people, that whenever there is a stress period, there is some increase in reflux, and which goes away once the stress is off. PPI has treated him. He is happy. The doctor is happy, and he can go on, move on in life without really worrying about things. But look at this other person. He keeps having heartburn for the last 4 years. And despite taking a PPI, his response is not very good. Somebody gave him a double dose, which we would all do. That when we see a person not responding for 1 dose of PPI, we double it. Now, when we double the dose, we increase the chances of reflux only about 15%. And in this case also, the doubling of the dose did not improve him. Now, why I mentioned dysphagia is in patients who have achalasia, cardia, sometimes the heartburn is perceived because of a lot of food stuck in the esophagus, and patients actually have a symptom of dysphagia. So whenever a person doesn't respond, ask for dysphagia. If dysphagia is there, we change our diagnosis. And here, let's see what we are going to do. So firstly, we ask the person, have you taken or hello? So persistent symptoms for
When
it.
I'm coming back on Sunday morning.
So I think there is some disturbance. Hello. Yeah. So in two situations. Hello. Can we mute? Excuse me. Komal, can we mute the other participants?
Yes.
Can we? There's a lot of
Yes, ma'am.
Sorry. So refractory GERD, that means a person who's not responding. One is that There is actually esophageal symptoms, which means heartburn, which is not responding. And in this case, the implication is that the symptoms may be or may not be from reflux. And the second one is a true refractory GERD, which means the patient actually has reflux. There is gastric acidity, but the patient is not responding. So there is different two types. One, there is actually no reflux. Therefore, the patient is not responding because his diagnosis was wrong. The second one, the patient has reflux, but treatment is not optimized or is not adequate. So most of the causes are either due to a wrong diagnosis or that the patient hasn't been taking his treatment properly. So in this, the first one is the drug. Now, many people initially are told, and we keep on telling them that take the drug on an empty stomach, but the patients forget. So they take it at any time. And quite often the response to the PPIs is then not as optimal as you would want it to be. So it's important to keep on reiterating that please take the drug before breakfast. So the drugs that do not need do not need an empty stomach before absorption. The two drugs, one is dexlansoprazole and the other one may be the new one, that is vonoprazole. So the other thing is all human beings have this attitude that if we are better, we will stop the drug. Now in patients with mild GERD, that's fine. But in patients with severe disease, they need to take the treatment continuously because they're going to otherwise get symptoms. And we all know that if we have to take this medicine for 6 months every day, once in a while, we are going to skip the dose. And that is where the problem is, that many patients, after about a few months of feeling absolutely better, they stop the treatment. And then they come back with recurrence of symptoms where the actual problem is not the drug, not the disease, but the fact that compliance has not been taken. Second, even when the esophagitis is healed, that means there is no damage now, patients continue to have a little bit of visceral hypersensitivity, and therefore almost 30% of patients continue to experience some symptoms. So there is no GERD, but there is hypersensitivity here. So now what should we do? So on visit 1 in this 54-year-old patient, we started him on PPI. He didn't respond. So the next best thing, and quite often, even the first time that a patient comes, he is referred for endoscopy. When he is referred for endoscopy, it is to look for any damage that may be there. Unfortunately, endoscopy, though it is extremely specific, it is not sensitive. Almost in 80 to 85% of patients who visit us, that is because we are a tertiary referral center and because patients have already received their PPI before they came to us, 80 to 85% are actually normal endoscopy. We do biopsies, it's normal. So if the patient has GERD, only about 10% are picked up at endoscopy in tertiary referral centers. In primary and secondary centers, this figure goes up to about 20%. That means in 60 to 70% of cases, the endoscopy is going to be normal. So when we do the endoscopy, we look at whether there is any damage. So this is very mild damage. We call it grade A esophagitis. But when there is severe damage, I hope you all can appreciate the slides. You see this redness here, there's a lot of scarring in the esophagus. We call it severe GERD. In here also, you can see the severe thing. But sometimes we may find other diagnoses. For example, we may find candidate. We may find HSV or viral esophagitis. Sometimes in patients, especially those who have asthma, those who have atopic dermatitis and eosinophilia, we might find eosinophilic esophagitis. Now, this is a ringed esophagus, which is very classical of eosinophilic esophagitis. And this is a diagnosis that can be missed if we do not look carefully during the endoscopy. So the first thing is to take a good history, especially when the patient has allergies, increase in esophageal counts. And if there are some abnormalities, we take a biopsy to see whether we find anything else. Though the patient has classical symptoms of heartburn and sometimes regurgitation. Now in this 54-year-old man, he had gone to 2 gastroenterologists before he came to me, and we found that his endoscopy report was normal. So therefore, we did not want to repeat endoscopy. We would repeat endoscopy if we thought that biopsy would help, but otherwise there's really no need of repeating the endoscopy. So now what should we do? We're coming back to the same slide where I'm saying the same thing and repeating it, that there's one thing where the patient is not responding and one thing where the disease is not responding. So the first one, we're not sure whether it's reflux. The second one is definitely reflux. So what are we going to do now? So now our basis is to find out, is reflux present? And if reflux is present, is it the cause of symptoms? Otherwise, is there something else? Now, this is a whole multitude of tests that we can do after we do the endoscopy. And we do this test only if endoscopy is normal. If the endoscopy is abnormal, we do not do these tests. Now, here we do a pH metry. Now, what is pH metry? pH metry, we put in a tube through the nose and measure the pH or the acidity in the esophagus. And we want to know whether that acid content is higher in patients with GER, and therefore can we do something. But before that, we do a manometry for a reason. So what is esophageal manometry? Here again, we put a tube through the esophagus and we measure pressures. And you see this panel on the left that when we give a swallow, the wave moves and there is a peristaltic wave. For understanding it, this is the upper esophageal sphincter. This is the lower esophageal sphincter. And you find that there is peristalsis or contraction and the food bolus is shifted down. The panel on the right is in a patient who has dysphagia. You see that there is no peristalsis and this contraction is almost looking as if there is the same pressure wave simultaneously throughout the esophagus. This is a patient with achalasia. So this was more of showing what manometry looks like. So what is manometry? It tells us what the swallowing is like. We want to know whether there is normal peristalsis. So we look at the esophagogastric pressure, which is usually low in patients of reflux. The second thing we do is to look at the peristalsis. And you see this peristalsis here, which is sometimes abnormal in patients with reflux. I'll be coming to that. And then the newer technology is that besides this, we can also do a video fluoroscopy at the same time and check whether the bolus actually moves forward, because manometry only tells us about the pressure. In the last 5 years, we've moved up from only manometry and we now do what is an impedance manometry. And it combines the strength of manometry along with a fluoroscopy, and I'll just show you. So one picture will almost look like a barium and the other one will look like a manometry, and then we overlap them. So these are the new catheters and all that which are available. So let's look at this. Here is what I showed you previously is a manometry. This is the upper esophageal sphincter, the lower esophageal sphincter. And here you see that the pressure is normal. And this is the impedance, which means that this is testing whether the bolus or whatever we have taken, it may be food or it may be a liquid, is traveling down the esophagus and emptying into the stomach. So in this case, we find that this purple has emptied completely, and therefore this is a normal manometry. So this is a normal swallow, again with the overlap. And let's see what happens when there is ineffective motility. So whenever a person has a weak esophagus, the swallow here looks as if this peristalsis is weak. But when you look at the esophagus, you find that there's a lot of bolus or whatever he has taken is still lying in the esophagus. It has not slid down the stomach, and the patient may then feel this regurgitation or heaviness in the chest. Sometimes you can see that there is a person who's actually not having reflux, but he's ruminating. So he's trying to bring the food up, and this food is now lying in the esophagus, and then he finally swallows it as normal. The other thing is a supragastric belch. The patient keeps on swallowing extra, brings out the air, this black is the air, and then throws it out. Here, there is no LES relaxation, but actually the patient is tightening the diaphragm and bringing out the stuff in reverse. It is not going forward. So in a patient, this patient, we found that there was actually a reflux episode which we could see. Second, we found that he had a hiatal hernia, and you see this, there are two pressure bands, one here, which means one is the lower esophageal sphincter, the other is the diaphragm. And here also you see that the food is actually staying for a long time in the esophagus instead of pushing it down very well. So in reflux, we might find a hiatus hernia and dysmotility. Okay, so the next investigation, now we've seen that the manometry was showing a weak LES, a weak peristalsis, and a hiatus hernia. So now we go to what we call is a pH monitoring, and I'll run through this to explain what is impedance pH monitoring. So just like in manometry, we had introduced impedance, we're going to introduce the same thing in pH and see where the acid is moving. So if the impedance is moving backwards, it's moving backwards in terms of time, we say this is a reflux. If it is moving forward, we say this is a swallow, or that this, or sorry, this is also backward, but this is non-acid. If you look at the pH here, I'm sorry, I made that mistake. This is the pH here. You see that the pH has dropped. So therefore, this is acid, and this pH has not dropped. So this is non-acid. Just going through this quickly, impedance technology, I told you all that the bolus moves up. As the bolus moves, you find that the impedance drops. Okay, and this is how we just look at this. I'm not going to take this to detail. And this is how the impedance moves. So pressure comes after the impedance, and when there is reflux, we see this impedance wave and then check the pH and see whether it was acid or non-acid. So just showing this, you see that this is an impedance wave here, where the impedance has dropped. That means there is fluid in the esophagus, and at the same time, the pH has dropped, and therefore this is an acid reflux episode. So this is again a weakly acid or a non-acid, where the reflux is there, but there is no drop in the pH less than 4. This is the same thing repeated. This is normal on the left, and on the right is a reflux. So impedance values, when we see, if we see more than 80 per 24 hours, they're abnormal. And then you look at the pH and see whether it is acid, non-acid, or weakly acid. You can also assess whether it is liquid or gas. In addition, we can look at the symptom indices, which means that when we ask this patient in 24 hours, did you get symptoms? And then we divide the number of symptoms by the total number of reflux episode, and have this 2x2 table drawn. If the patient has the symptom and there is pH change, we say that it is a positive correlation. If the pH does not change, we say it is a negative correlation. And based on this, we can say whether the patient has sensitivity or reflux-induced symptoms or not. So in this case, our pH metry was normal. Okay, now what should we do? So we now move to a spectrum of diseases where manometry is normal, pH metry is normal, which means that this patient does not have significant reflux and this patient's symptoms are coming from somewhere else. So first is functional heartburn. Here the patient continues to have heartburn and there is no symptom relief despite optimal therapy. Second, our pH metry is going to be normal. Endoscopy is normal and endoscopy esophageal eosinophilia is not there. We have also ruled out other causes like achalasia and other causes of esophageal disorders. And that is what we say is functional heartburn. As I said, in this patient, the pH metry was normal. The second thing in this same spectrum is where the first three are absolutely normal. That means the symptoms are there, endoscopy is normal, but on pH metry, we might find that the patient presses the button saying that he has the symptom, and at the same time, there is a reflux episode that we record. And that is what we say is a high symptom index. And here we say normal pH, but the symptom association probability is positive. Whereas in functional heartburn, the symptom association probability is negative. In both, the symptoms are the same. The manometry findings are similar. The pH metry is absolutely normal, but it's only the symptom association probability which changes. And that is a new spectrum that we will see. So if the pH was abnormal, so we're coming back to reflux, the treatment is optimize the acid suppression and to reduce the TLESRs, which means that we are giving drugs to change the LES relaxation. That is baclofen is used. It has a lot of side effects, but that's the only drug. And we can use Gaviscon because it creates a nice float at the stomach level. And therefore, the reflux does not happen. Now, we have a lot of prokinetics available in the market. Remember that none of these prokinetics affect the esophagus or the lower esophageal sphincter. They are good for emptying the stomach, but they are not good for emptying the esophagus. So in patients who have bloat, who have diabetes with delayed gastric emptying, domperidone and etopride are extremely good drugs. However, there are patients who have early satiety and feel that they cannot eat much. They still have reflux. In that case, the drugs to be used are acoshamide and levosulfide. Just one thing about levosulfide in young women, it can cause hormonal imbalances, hyperprolactinemia, and therefore be careful with its use in young women. In reflux hypersensitivity, our first two drugs are the same. That means we increase the acid suppression using dexlansoprazole or vonoprazole because these are more effective than the others. TLSA dissection we can try, but then we move to pain modulators. I'm coming to that. My screen seems to have frozen. Just a minute. My screen seems to have frozen. In functional heartburn, because everything is negative, adding a PPI is not really going to be useful, but patients are not going to stop taking it. they'll take it on their own. But here we talk to the patient, sometimes involve a counselor and give them either tricyclic antidepressants if they do not have constipation. Tricyclic antidepressants, if they have constipation, are not a good drug. Second, we can use SSRIs and help the patient. Just a minute, my screen seems to have stuck. So steps to managing esophageal pain and refractory heartburn is ensure proper diagnosis. So history, endoscopy, manometry help us. Yeah, I'm almost finished. Eliminate noxious triggers. And here, this is another one where the patient had the same symptoms, and we can use modulators, treat the anxiety and depression. And this is the final slide. If the patient doesn't respond or heartburn is still continuing despite treatment, then in that case, do a pH-metry combined with a manometry. And if that is positive, maybe we optimize acid suppression and give biofeedback, baclofen if the patient is not responding. And in patients who respond well, so it's important, patients respond well, there is positive reflux, only then and then send them for surgery. Otherwise, we get into trouble. So the final slide, we create whether there is reflux, yes, no. If there is reflux, is it acid or non-acid? And if there is no reflux, of course, the treatment is changing. We have to exclude disorders like achalasia or heartburn or functional heartburn. And that is where I end my talk. Thank you very much. I would be willing to take any questions if there are.
Yes, ma'am.
Yes, hello, madam. Yes.
There is a question. Contraindication using PPI, especially if taken for a long time.
So that is a very interesting question. And in the last maybe 10 years, there's a lot of this noise about PPIs causing side effects. But believe it or not, in the last 30 years of my practice, I have seen only 2 PPI side effects, real side effects. One was creatinine going up, and in some patients, you get diarrhea. So there are big studies showing that the only side effect that PPIs really have is increase or change in the bacteria of the gut. And some of these patients can develop diarrhea. In patients with cirrhosis, they can develop severe diarrhea, and they can also develop SBP. But in other cases, there are hardly any side effects that we see.
Okay, there is one more question. Treatment for excessive belching, patient is not psychic.
Okay, so that's a very important question. The patient is not psychic. Excessive belching is actually a response to increase in swallowing.
Okay.
See, the belch is air. Now the stomach doesn't produce air after digestion of food. So the air in the stomach has to come from swallowing. So though patient is not psychic, if you observe them, you find that they are actually swallowing extra. You keep looking, instead of watching their face, watch the throat. And you see that they are silently swallowing. They will swallow 4 or 5 times, and then they will bring out a big belch. And then they will say, if somebody presses me here, I will belch, which is normal, which is natural. So in the OPD, we see a lot of these. One of the ways is to break this cycle is by increasing their knowledge about it. So one of the things that we do is tell them that when you're subconsciously sitting in front of the television, take a spoon and put it across the mouth. By opening the mouth or not closing it completely, it is very difficult to swallow. When they don't swallow air for say 15 minutes, then they don't belch. And then they realize that it may not be psychic, it may just be a small response to stress. So the best way is to break the cycle, what we also call as cognitive behavioral therapy.
Okay. There is one more question. Can we combine PPI with famotidine?
Yes, not as one drug. So there are some patients who have a lot of nocturnal symptoms. And then we give them PPI in the morning and 1 dose of famotidine in the night. See, the advantage of famotidine, it acts very fast. So sometimes if you had a heavy meal, we can take famotidine and be done with it. Okay.
Now the last question, the cost of manometry, fluoroscopy and impedance.
So manometry with impedance is actually depends from place to place. We have now got the latest model. Of course, we're not going to increase the cost, and we are not now doing manometry only with impedance. We are not doing routine manometry, where we are not measuring pressures. And the cost is about 7,000 to 9,000. Okay. pH metry, it's the cost of the catheter, which is important. So the catheter cost is about 14 to 15,000 anywhere in the world. So that catheter cost, along with the cost of the procedure, works out to about 20,000.
Okay.
Okay. So we do this mainly in patients who are going to go for surgery, because we want to make sure that we are not missing another diagnosis. If a patient with heartburn who doesn't have reflux is operated, there will be no relief, but we may get a lot of complications after that. I must thank the IMA for giving me this wonderful opportunity. And I thank all of you for having listened in on a Sunday morning. Thank you, madam.
Yeah, thank you so much, madam, for giving wonderful information about the acid reflux in gastrology. Now the next speaker is Dr. Nilen Shah. Dr. Nilen Shah is our good friend. He is a consultant, orthopedic and joint replacement surgeon at Sir H.N. Reliance Foundation Hospital and Research Center. After completing his MBBS from TN Medical College, Mumbai with honors, he did diploma in orthopedic with second rank, followed by MS Ortho Mumbai with gold medal. He also secured MCH Ortho from University of Liverpool, UK. He also did a knee fellowship at the Avon Orthopedic Center, Bristol, England. He is involved in performing approximately 1,000 knee joint replacements a year in Mumbai, along with a group of 4 fellow surgeons. He has pioneered the sub-Western approach in knee replacement surgeries that is only minimally invasive. He is a reviewer of the Indian Journal of Orthopedics and British Journal and Joint Surgery. Today, he will be talking to us as a short stay knee replacement. Over to Dr. Nilen Shah. Welcome.
Thank you very much. Thank you. And I must thank the IMA and Reliance Foundation Hospital for giving me this opportunity. Can everybody hear me?
Yes.
Yes, yes.
Can the screen be seen?
Yes, yes.
Is my screen seen?
Yes, yes, we can see it.
Yes, sir.
Okay. So a good morning to everybody, and let's hear my short talk about short stay knee replacements. So there are various beliefs about knee replacements in the society. The first belief is that everybody thinks that it is an extremely painful surgery. It carries significant risks and may involve an ICU stay. Generally, blood transfusions are required. People stay for up to a week in the hospital. Extensive physiotherapy may be required. Walking aids may be required for a month to 6 weeks. Short stay knee replacement or outpatient knee replacement probably is out of question. Now, great advances have taken place in pain management. There is this concept of preemptive analgesia. That means analgesics have to be given before the pain stimulus occurs. But we must avoid narcotics and epidurals because narcotics produce nausea and a feeling of well-being, but people can't really eat and drink well. Epidurals generally would act on both the lower limbs, and people would require a urinary catheter and would prevent them from mobilizing. And the world is shifting to nerve blocks. So currently I find that the patients that I operate, most patients are so comfortable and they are surprised as to how painless the operation has become, quite contrary to what their ideas were. Now, we must understand that surgical patients should not become accident victims, because good management of the pain can make or break the success of the operation, and I would say even the surgeon. So if some surgeons' patients are very, very painful post-operatively, not many people would prefer to get operated by that surgeon. So surgery in India is a social event. Whether we like it or not, there are going to be visitors who will visit the patient. So how the patient is on the evening of the surgery is critical for popularity of that surgery and for popularity of that surgeon. Now, surgery causes tissue trauma, inflammation, which leads to pain. So our aim should be to control inflammation without hindering the healing response. Tissue injury causes inflammation, which stimulates the nerve. Peripheral nerves get stimulated. Stimuli go to spinal cord and then to the brain to tell us that it is painful. Now, fortunately, we have parameters which can act on each and every part of this. So tissue injury can be reduced by minimally invasive surgery. Inflammation can be reduced by COX-2 inhibitors. Nerve stimulation can be reduced by giving local injection, nerve blocks, steroids. Peripheral nerve can again be reduced by giving spinal and COX-2 inhibitors and narcotics. And narcotics and COX-2 can also act on the brain to reduce the amount of pain sensation that the brain perceives. We want to avoid narcotics because it causes nausea, hypotension, and malaise. Epidural, as I said, because of hypotension and urinary retention. So my current practice of managing pain in collaboration with the anesthetist is to use a spinal anesthesia, even for bilaterals, avoid epidurals, intraoperative cocktail, give a nerve block, femoral or adductor canal, and use adequate and safe non-steroidals. Intraoperatively, one would use a muscle sparing surgery with an adequate incision, avoid the use of tourniquet. One needs to have a rehearsed operative steps with a dedicated team, use tranexamic acid, use local anesthesia capsular cocktail, a tension-free watertight closure, and insertion of adductor catheter by the surgeon himself. Now, as we all know, tourniquet is extremely common in many orthopedic operations. The pressure that is utilized is 100 to 150 millimeters more than the systolic, and it may be used for as long as 2 hours. It is believed that it reduces blood loss. It is believed that it improves the cement-bone bond. But what it actually does is just improves the surgical comfort. So using the tourniquet is like these 4 men saying, where is the blood loss? What is the blood loss? When I was operating in mid-2008, unfortunately, I had a vascular injury. I missed it because of the tourniquet, and I have not used a tourniquet since. And in fact, my patients are happier. Now, one may ask why that is so. Because by not using a tourniquet, there is less of deep vein thrombosis, pulmonary embolism, cardiorespiratory events. less nerve or muscle damage, less pain, and less of toxemia. Now just imagine what happens when a tourniquet is inflated. Inflating the tourniquet gushes in around 500 cc of blood, whatever is the blood volume in that lower extremity, into the systemic circulation in less than a minute. When you suddenly push this blood in the systemic circulation, it is bound to increase the blood pressure. Similarly, when you deflate the tourniquet, similar amount of blood volume is lost from the circulating volume, and this causes a fall in the blood pressure. Now, do we really want this kind of fluctuation in the blood pressure in our elderly patients? And if we do not have this, then obviously the cardiorespiratory events are going to be less. A very interesting study was done by Keto et al., in which they did transesophageal echocardiography for all patients with and without tourniquet. They found 100% incidence of thrombi at tourniquet deflation by a transesophageal echo. Clinically proven pulmonary embolism was there only in one patient. Thrombi also occurred in the non-tourniquet group, but these were clinically irrelevant. Now, all of you who are clinicians and take blood pressure, you know that if you leave a blood pressure cuff on somebody and answer the phone, and if the pressure is still raised, the person starts complaining of tingling and pain in the thigh and in the arm. Here the pressure is only systolic. The duration of the tourniquet is only seconds. I wouldn't say a tourniquet. BP cuff is only for seconds. When a tourniquet is utilized with a patient under anesthesia, the pressure is not just above the systolic, it is 150 to 200 millimeters above the systolic blood pressure, and it may be left on for 2 hours. So I put it to you, muscle and nerve damage due to tourniquet, is it far-fetched? Is toxemia far-fetched? And I'm sure you all have heard that people have developed tourniquet palsy. Some people have even developed thrombi in the legs because of tourniquet. So it is best it is not utilized. So disadvantages of a tourniquet are more pain, less range of movement, nerve and vessel injury, muscle damage, wound healing issues, cognitive dysfunction, increased thromboembolism, and increased actual blood loss. Now, how would a tourniquet lead to greater blood loss? It does because it increases the hidden blood loss. Blood loss that occurs during the time of surgery is the evident blood loss, and patients lose blood because of secondary hemorrhage, which gets increased because of tourniquet. Now, the other question is, can tourniquet improve a cement bone bond? Now, loosening rates of our totally implants will be correlated with early migration. So radio stereo assays were done where tantalum beads were put inside the implants, and migration was studied at various intervals post-surgery in patients who had tourniquet on and patients who did not have tourniquet on, and they found that the loosening rates which correlate with migration were the same in patients with tourniquet and without tourniquet, which shows that even if a tourniquet is not used, the cement bone bond can be really secure. So why are people still using tourniquet? Because they have got brain blinkers on. Fortunately, in the year 2007, tranexamic acid came into the market, and we have had extensive experience with its use. As we know, it is an antifibrinolytic, not a procoagulant. It has no action on intact vessels. Safety profile is high, although we should use it with caution in patients with previous VTE and renal failure. And according to me, it is a game changer. And we have an experience of over 12,000 knees in which we have used this. Surgical trauma to blood vessels will cause bleeding. Bleeding will lead to coagulation, but the coagulation, the coagulum can be fibrinolized and which causes further bleeding. But tranexamic acid reduces fibrinolysis. We have devised methods to reduce blood loss in which we use tranexamic acid, we use saline adrenaline infiltration, and we also keep the knee flexed post-operatively so that the bleeding is less. We did a very interesting study which has been published in which we used no tourniquet and tranexamic acid, and we found that none of our patients required a blood transfusion. Whereas if you use tourniquet or you do not use tranexamic acid, then the rate of blood transfusion is higher. So we were able to show probably the least drop of hemoglobin in our patients. Our studies have been published about strategies to reduce blood loss and knee replacement. We also did further research on tranexamic acid, and this paper has been published in the Journal of Arthroplasty, which is the most premier institute of knee replacements, premier research journal of knee replacement, in which we combined systemic and topical tranexamic acid and found that it can be a better regime. We have also sent another paper on the use of oral tranexamic acid post-surgery, and this has also been accepted for publication in an international journal. Now, coming to nerve blocks, now femoral nerve block, I started probably in the year 2000. It is very effective in relieving pain. It is ideal as it does not require a urinary catheter. And spinal and femoral was the combination for a number of years. But the disadvantage was that it weakens the quads and it can delay mobilization. So here I am. The knee replacement has been done, but to reduce pain post-operatively, I am isolating the femoral nerve with a femoral nerve stimulator and then injecting a local anesthetic to anesthetize the nerve. And then when I have fully isolated the nerve, I'm putting in a catheter, as you can see here, where local anesthetic can be instilled at repeated intervals for the first 2 days so that the person does not get any pain. The adductor canal block came in after this femoral nerve catheter, where the nerve is blocked after the motor branches to the quadriceps are already given out. So we do not get any weakness of quads, and patients can walk comfortably within a few hours post-surgery. It can be USG guided, that is the norm currently, by the anesthetist, or it can be direct surgeon administered, where we have just started doing this. I was so impressed by this that we did a trial of femoral nerve block and adductor canal block. Again, this has been published in the Journal of Arthroplasty in the year 2014. So when we took this on, it was so new for the whole arthroplasty world that it got easily accepted in a premier journal, where we showed that adductor canal block is better for functional recovery, but the pain control is similar to femoral nerve block. And we also showed that a continuous adductor canal block is better than a single shot adductor canal block. Currently, we are doing a trial comparing anesthetist administered adductor canal block and surgeon administered adductor canal blocks. And this is underway. Now, obviously, knee replacement has some risks of DVT, PE, infection, medical complications, but advances in our understanding and prudence in patient selection have reduced these to less than 0.5%. So on the whole, this has become a very, very safe surgery. The need for physiotherapy and walking aids have reduced drastically after we have utilized the subvastus approach routinely. And as we know that the only thing constant in life is change. If we do not progress, we become irrelevant. And although we are molded by our past, we should not become its prisoners. So let us listen to what a Now, how does one get such a result? Obviously, we need to do a perfect surgery. We need to manage the pain well. We need to do adequate preoperative counseling. But the patient also needs to be well motivated. So to do a short stay surgery or an outpatient surgery, you need to do a minimally invasive knee replacement on an appropriate patient, manage the pain well, have adequate physiotherapy team. So the whole team approach will be able to get you there. And I'm happy to state that at HN Reliance, we have this team approach perfectly in place. So mini subvastus knee replacement is a primary requirement. As we do not cut the quadriceps, muscle remains intact. There is less pain, more power, and easier and faster mobilization. This was the classical medial parapatellar approach to the knee. It was the workhorse, and it is most common approach still utilized in various parts of the city and the world. Subvastus approach has been described in German literature more than 100 years ago. Hoffman described it in English in 1991, and I have been using it routinely since 2005. Extensor integrity, less pain, better patellofemoral tracking. These are the advantages. In mini subvastus approach, we would use a smaller incision, concept of a mobile window to expose different areas of the knee, sequential rather than simultaneous exposure, avoiding patellar eversion and tibiofemoral dislocation before the bony cuts, and slightly downsized instrumentation. In our experience, it is suitable for all knees, obese, severely deformed, previously operated, all comers. And I have had a very, very favorable experience. We have published our experience in obese patients, in valgus knees, in stiff knees, and even in revision knees. So in all kinds of knees, subvastus approach has been utilized, has been perfected, and has been published in peer-reviewed journals. The stability that you get on table, even with a spacer or with the implant, is so good that you feel as if nothing has been done to that knee because the patellar stabilizers have been not cut. But only surgery cannot deliver the result, and we must manage pain well if early recovery is desired. So once you manage the pain well, in around 2 to 3 hours, the patient is able to, or as soon as the effect of the spinal anesthesia goes, the patient is able to lift the leg up, bend the knee, let as many relatives want to come and visit the patient as required. Obviously, one should be careful about infection, and you know that she is going to do well post-surgery. So physiotherapy, we must give information preoperatively. We must reassure the patients that same-day walk, chair sitting, and use of washroom will be possible. And the patient must have had similar experiences of friends and relatives for them to feel reassured, for them to be able to go either on the same day or the next day of surgery. A motivated patient can do this. Obviously, if somebody has multiple comorbidities, we need to be sure that they are well under control. So we encourage the patients to go home if patients also so desire and it is medically safe. Currently, the Mediclaim is such that they have to stay in for 24 hours. So they stay for the night of the surgery, but a lot of people are able to go home the next day. So 1 night or 2 nights is currently the norm. Knee replacement, as you know, can be partial or total. In a partial knee replacement, we do a part replacement, preserve the ligaments in the other parts. The patients feel that the knee is more natural. Satisfaction rates are higher, but the downside is that the other parts can fail. But in selected patients, it can last as well as a total knee. I was involved in a randomized trial in UK where we did 50 knees of uni and total, completely randomized. And at 5 years, partial knee replacements did better than total. And this research was published in another landmark journal, the Journal of Bone and Joint Surgery. And these are some examples of partial knee replacements. Here you see that only a part of the knee is replaced, the other part is intact. And it has shown excellent survivorship in various series. Another example. So which patients are suitable for a partial? They must have an intact anterior cruciate ligament. The deformity has to be correctable. The flexion deformity should not be very high, less than 10 degrees. They must have a good range of movement, minimal patellofemoral symptoms. So varus that disappears on flexion. So worldwide, around 5% of the knees are suitable for partials. In total knee, there are various implant choices, but we must use a knee which mimics the normal knee kinematics because that will lead to better satisfaction. Ceramic knees have come in, and obviously this is a humongous success. There are various surgical gadgets. Navigation, I have used extensively. Robotics has just been purchased by HN Reliance Hospital. Patient-specific jigs adds, according to me, avoidable cost to the surgery. We have published our study on the use of navigation leading to optimal restoration of the knee axis post-total knee, again in the Journal of Arthroplasty. So friends, I believe that the KISS principle, KISS meaning keep it simple, is very important in life and also in knee replacements. Use a subvastus approach, do it tourniquet-less, don't use drains, no electrocautery, and sparing use of suction so that the knee, you disturb the internal milieu of the knee as little as possible. Post-op, use a cryo cuff. Cryo cuff is just a cuff that can be applied around the knee where you can put really cold water so the patient gets pain relief and the inflammation is reduced. Do an early rehab, allow the use of washroom from day 0 and have low morbidity. We have also studied the morbidity post-total knee replacements, and we have devised a score to assess the immediate post-operative recovery, which has also been published in the literature and it has been well accepted by the orthopedic community. Patients can go home when they are ambulating well, pain is under control, acceptable range of movement, the dressing is dry, and this happens in 1 or 2 days. So here you have a patient walking on the second day of bilateral knee replacements. And even if you want to keep this patient in the hospital, they won't stay. So they are ready for home. So the current status is that 60% of the patients go home on the first post-op day. That means if today is the surgery, next day they will be home. 30% stay 1 more day. 2% of the patients go home the same day and 8% stay more than 2 days. So I would say that short stay knee replacement is a reality and it is something that we are doing in and day out. And as soon as the Mediclaim issues get settled to make knee replacement an outpatient knee surgery, we will be ready to receive it. I thank you for your attention.
Thank you, Dr. Nilen, for giving wonderful information about the minimal invasive short stay knee replacement. Now I want to ask one question. What is the cost of this minimal invasive knee replacement surgery?
I think the cost for minimally invasive knee replacement surgery would vary depending upon which hospital and which room you choose in the city of Bombay. But it can be done for as little as 3 lakhs in a premier institute in a twin sharing room. And obviously, if you take a suite room or something, then the cost can be higher.
Post-operative physiotherapy, is it necessary? And if it is there, then when should the patient start?
right? This is a question that I often face, and the way I answer the question is that there are certain children that require a tutor for them to study, and there are certain children who can do self-study. So studying has to be done. Exercises have to be done, performed post knee replacement. Most people are able to perform the exercises by themselves. So they do not need a physiotherapist at home to do it. Plus now there is enough literature which is available freely. We have enough published material which is available freely, guidelines which are available. So people can follow those guidelines, even WhatsApp messages, even YouTube messages, even I have prepared videos which they can follow without the need of physiotherapists at home. But if some people want a tutor at home, then obviously the physiotherapy team is there. I'm not saying physiotherapists are not required, but the need for domiciliary physiotherapy has been drastically reduced because of subvastus knee replacements.
Okay. Any more questions? Thank you, Dr. Nilensha, for giving wonderful informations. Now we'll start with the next speaker, Dr. Pritam Jain. I request my IMA CGP member, Dr. Kashyap Dakshini, to introduce.
Good afternoon, friends. Dr. Pritam Kumar Jain is a medical and hematological oncologist attached to Bombay Hospital, Wokard, Fortis SL Raheja, Bhatia, Global Hospital, Masina Hospital, MPCT Hospital, and KJ Somaiya Hospital. He has his own oncological center, Jain Onco World, at Mahalakshmi, Mumbai. He's a graduate from Pondicherry University. Dr. Jain has completed his MD from BJ Medical College, Pune, followed by DM Oncology from Gujarat Cancer and Research Institute. He is an expert in chemotherapy, targeted therapy, immunotherapy, and hormonal therapy. He has skillful knowledge and inimitable proficiency in treating blood cancers like leukemia, lymphoma, and multiple myeloma. He is also an expert in treating breast cancers, colorectal cancers, lung cancers, sarcomas, gynecological cancers like cancer of the ovary and uterus, and pancreatico-biliary cancers, kidney cancers, etc. He is actively involved in conducting many campaigns with youngsters in promoting early diagnosis and screening for cancer. Today, he will speak on approaches to blood disorders, myeloproliferative neoplasms. Welcome, Dr. Jain.
Hello.
Yes, Dr. Jain.
Yeah, good morning to everybody. It's been a great Sunday morning, wonderful academic feast. I want to thank IMA for giving me this wonderful opportunity. All the distinguished speakers were awesome in sharing their expertise and knowledge. I've been listening to them. So the openers and the middle batsmen have done their job fantastic. So I'm the tail ender of the session. So I'll keep it short and sweet and try to entertain every one of you, will not bore you. Because most of the times hematology deals with a lot of molecular things. So let me just share the screen. I hope I'm audible to everyone clearly.
Yes, Dr. Jain, audible.
Thank you very much. Is my screen visible?
Yes, visible.
Yeah. Thank you very much for giving me this wonderful opportunity. I'm Dr. Jain. I'm a medical oncologist and I'm affiliated to various hospitals in South Mumbai. And I'm a freelancer, readily available for any of your patients for the expertise. And let me begin with today's session. Today's session that I'm going to deal with, the talk will be on myelofibrosis and polycythemia vera. So this is one of the spectrum of, myeloproliferative neoplasm. It's a huge spectrum. I I will not be going into the detail of all the spectrums, and the topic will be confined to these two aspects, because most of the times these two are untouched, untapped topics, and they mimic very common diseases like benign diseases. So the topic sessions will be in the form of awareness, signs, symptoms, and diagnosis, nothing specific from treatment point of view. And so let me begin with a case report, all right? So we have one a 62-year-old retired school teacher. They presented to the physician with, regular health checkups, and what I could feel that, this patient had reports of fatigue during the last few months and has been experiencing night sweats. Although, this she explains that this is probably because, she's been working hard, and due to a return of the hot flashes she experienced after, menopause. So the key word is fatigue and night sweats over here. Further questioning, these two symptoms are associated with significant weight loss. So most of these patients come also give a history of weight loss, which again gets confused with maybe I'm stressed out, I'm not eating well, so I've got a weight loss. So again, it mimics certain other parameters also. And most of these patients do not have any comorbid conditions, and they are pretty fit otherwise. She's not been on dieting. However, she says that she just cannot eat as much as she used to, which she attributes to getting older. So classically they present with fatigue, night sweats, weight loss, and not eating appropriately as like before. This is how things comes, and these are very non-specific symptoms, because of which patient might never come to the oncologist the initial symptoms. So when they approach to us, what we do is we start thinking in all the directions. And on examinations, what was important that they might have sometimes a bruising, okay, on the extremities, and there might be a palpable splenomegaly. So whenever you have some bruise, mild or moderate splenomegaly, and certain constitutional symptoms, immediately we want a very comprehensive hematological workup. So when I did a CBC of these patients, like you see, generally the parameters are something like this. The WBC is slightly on the leukocytosis side. There is anemia. So cytopenia is one of an important manifestation. Either it could be isolated anemia, or it can be accompanied with other cytopenias. So in this case, there is only low hemoglobin, and the platelets are pretty okay. And another important diagnostic features that we expect or we do is lactate dehydrogenase level, which is also elevated in these myeloproliferative neoplasms. The rest of the LFTs and creatinines are normal. So if I have such scenarios where there is anemia, splenomegaly, elevated LDH, then definitely I start looking into the bone marrow, and we have to prescribe the prescription for the bone marrow examination. So we decided to proceed with the bone marrow biopsy and cytogenetics to predict whether is there any evidence of myeloproliferative neoplasms. Now, so basically, to understand the whole pathophysiology, you see, in short, I'll be using this word as MPN. What are these MPNs? These are clonal disorders of hematopoietic progenitors. So it's essential to understand what are the progenitors. If we go back to our basics, right from the bone marrow, we have the hematopoietic stem cells, from which is divided into lymphoid and the myeloid progenitor cells. In the myeloid progenitors, this gets matured in the form of a myeloblast, and from the myeloblast we have the final cells in the form of monocytes, eosinophils, neutrophils, and again from there we have the erythrocytes. So in MPN, there is disruption of this myeloproliferation, which includes both hematopoiesis and thrombopoiesis. That is this. So this myeloblast is what is involved in the whole myeloproliferative neoplasm spectrum. As a result of which, any abnormalities at the signaling pathway, it disrupts the whole process, thereby leading to myeloproliferative neoplasms. So the myeloblast, which includes monocytes, eosinophils, and neutrophils, and the other are the erythrocytes. And see. So this is the proliferative neoplasms. Increased production of one
Sir, we could not hear you. Friends, there's some connectivity issue. Kindly wait for some time.
hello. Hello.
Yes.
Am I audible? Is my screen visible?
Yes, Dr. Pritam Jain, you are audible. We cannot see your screen at present.
I just share the
Yes, we can see your screen.
Am I audible?
We can see your screen, but not completely audible.
Sir, your voice is breaking.
Friends, please bear with us. We're trying to re-establish connectivity with Dr. Jain. You want video?
Yes. Sir, your video is there. We are no audio is not there.
Hello, is my screen visible now?
Yeah, yeah.
Okay, thank you. Sorry for the trouble. There is some disconnectivity. Okay. So let me come back to this slide. The myeloproliferative neoplasms, generally we classify, based on two important factors, whether the BCR-ABL is positive or BCR-ABL negative. Because once the BCR-ABL is positive, there is a separate entity called as chronic myeloid leukemia, and the whole treatment line changes. So whenever we have a suspicious of myeloproliferative neoplasms, the first thing we ensure that whether the BCR is ABL is done or not. Okay, so if this is done and if it's negative, then these are the spectrum of the diagnosis that we think about it, of which myelofibrosis and polycythemia vera is what I'm going to confine my topic for today's discussion. So this is the classification. The WHO classifies MPNs in two groups, whether it's BCR-ABL1 positive or BCR-ABL1 negative. Now, these represents a major subgroup among myeloid neoplasms. Number one is essential thrombocythemia. Number two is your polycythemia vera. Number third is the chronic myeloid leukemia. This is a very important separate entity and requires another session of discussion. So I'm not going to talk about chronic myeloid leukemia. Now, what happens is that both polycythemia vera and essential thrombocythemia both can end up with myelofibrosis. So patient may be diagnosed with PV or ET, but at the end they may end up with myelofibrosis, or patient may be diagnosed with myelofibrosis and ends up with the primary cause being these two. So both are interconnected, and it's important that what exactly is the underlying etiology. And what happens is that once you know that the diagnosis is myelofibrosis, all the spectrum can ultimately, ends with acute myeloid leukemia. So once acute myeloid leukemia is diagnosed, it has an extremely grave prognosis and needs to be treated as a separate independent entity. Fine. So this is how the spectrum works. It's a pretty heterogeneous disorders, and one need to understand that where does the patient fits into which particular diagnosis. The other spectrum is what in short form we call it as CEL. Then we have CNL, where today's topic we will be just confining ourselves to polycythemia vera and the myelofibrosis, and take this forward. Myeloproliferative
Disconnected.
Yeah, so is the screen visible now?
Yes, visible.
Right. So the myeloproliferative neoplasms in 2008, the WHO classified in this format. So myelofibrosis, polycythemia vera, essential thrombocytosis, CML, CNL, eosinophilic leukemia, and mastocytosis, of which the common clinical scenario are these initial four. These are extremely rare, and I'll be confining the topic with PV, and myelofibrosis. See, myelofibrosis incidence is suspected to be underestimated, and most literature reports includes only primary myelofibrosis. That's precisely what we, generally diagnose it in our clinical scenario. Now, coming back to the first case scenario, which I had mentioned earlier, we proceeded with the bone marrow biopsy, which shows megakaryocyte proliferation and atypia with evidence of reticulin fibrosis. So these are the important fibrosis. Very important finding is erythroblastosis, right? And that's how precisely things happen. So the BCR-ABL is negative in these cases, and JAK2 comes out to be positive. Once the JAK2 comes out to be positive, we label the patient as probability that the polycythemia vera or essential thrombocytosis has ultimately led to the myelofibrosis. So this is the diagnostic criteria. So in the diagnostic criteria, we have major criteria and the minor criteria. It is important that all these criteria are met before we conclude the diagnosis. So there are 3 major criteria, and one of any 5 minor criteria needs to fit into the diagnosis. In the major criteria, as mentioned, there is megakaryocytic proliferation and atypia, and there is always reticulin or collagen fibrosis. Generally, we have hypercellular bone marrow, and the granulocyte proliferation is also there. And there is decreased erythropoiesis, as a result of which patients ends up with anemia. Also very important that these patients do not meet the criteria for CML, PV, ET, MDS, if you want to label this as primary. If any of this is positive, then it becomes secondary myelofibrosis. And presence of JAK2, calreticulin, and MPL marker, we end up with the conclusion of the diagnosis, and this might be a little bit exhaustive financially to the patient, and they might get confused what exactly is the diagnosis. But we have to understand it's a heterogeneous disorders, and no size fits to everybody. In the minor criteria, there has to be some leukocytosis, palpable splenomegaly, anemia not contributed to any other factor, leukoerythroblastosis, and increased LDH. These are the important minor criteria. All these criteria were fitting into the patients, and we ultimately ended up with in labeling these patients as myelofibrosis. Now, myelofibrosis is a condition in which the normal bone marrow, which is the source or the factory for all the red cell production, white cell production, is completely replaced here by the fibrous scar-like tissue. There's a beautiful picture over here of the bone marrow. These are the hematopoietic cells, and there are few fat cells. In what happens is myelofibrosis, there's absolutely no hematopoietic cells. The whole thing is fibrosed, and they turn out to be stain positive for the fibrosis. This is exactly how it looks in the bone marrow in myelofibrosis. Either it could be primary or secondary. Secondary, it could be because of the polycythemia vera or essential thrombocythemia. So patient present because the treatment varies negative, we label it as primary during the treatment process. So it's a big spectrum, difficult to make the patient and the family understand that in which direction it's going. To satisfy the patient's expectations again becomes a huge challenging for oncologists like us, but that's how it works. And we have to understand this bone marrow disorders are pretty high risk patients most of the times. So it's important that we understand the pathophysiology. In simple words, to remember, there is extensive fibrosis of the bone marrow, because of which there is anemia and cytopenias. So generally, there are 2 phases in this myelofibrosis. One is the cellular phase, the other is the fibrotic phase. So initially, you may have isolated anemias because there is hypocellular bone marrow. There are large cells, abnormal megakaryocytes that grows in clusters. As the disease progresses, the whole marrow is completely fibrotic in nature, and that leads to fibrotic phase. And this leads to a grave prognosis, and we have to understand and counsel the family members. There is a fibrosis as a result of cellularity is good. That's why the cytopenias are not severe. Later on, the marrow cellularity decreases. The whole marrow is completely jam-packed with fibrosis. There is osteosclerosis, excessive fibrosis. Now, what happens? The defense marrow called as extramedullary hematopoiesis because the hematopoiesis. So as a result of which extensive bone marrow fibrosis displaces the cellular hematopoiesis like spleen. Hence, spleen becomes the principal site of extramedullary hematopoiesis. This leads to splenomegaly. And once sequestered within that organ, now this leads to anemia, leukopenia, thrombocytopenia. That's how simultaneously there is something entity called as ineffective hematopoiesis, because of which there is leukoerythroblastosis. What are these leukoerythroblastosis? These are nothing but because of the ineffective hematopoiesis, there's a release of nucleated red effective hematopoiesis. Then there could be basophilia also. So this is a distinct bone marrow biopsy pathology report. We have early stage and advanced stage. In early stage, it's hypercellular in nature. You can see certain small red, blue dots. These are hypercellular hematopoietic cells. Gradually as the days progress, the whole marrow is completely replaced with collagen and fibrotic tissue, and there is osteosclerosis. Once this stage sets in, prognosis is extremely bad, and you have to counsel the patient that this could be irreversible and cannot be cured from here onwards. So there are diagnostic criteria of secondary myelofibrosis, like secondary to polycythemia vera or secondary to essential thrombocythemia, is also been declared by the IWG-MRT criteria. These are the group of association who does this work. Now, once again, it's important, the myelofibrosis criteria and presence of JAK2 mutations, and simultaneously the polycythemia vera. Generally in polycythemia vera, the is my screen visible now?
Yes, Dr. Jain, it's visible now.
All right. There are a few additional criteria that has been described in my case scenario, like anemia, leukoerythroblastosis, splenomegaly, and development of constitutional symptoms, which was all there in our setup. Similarly, if it's essential thrombocytosis, then you need to have those high platelet counts, not reacting to any other abnormality and purely clonal in nature. That's precisely what is required. And simultaneously, the myelofibrosis clinical picture is documented. So this is how we try to diagnose all these parameters, labeling as secondary myelofibrosis. Now, once the diagnosis sets in, there are prognostic scoring system. We use certain tools to prognostic the score and understand the survival of the particular patient. These tools are commonly called as IPSS scores. Okay, it is International Prognostic Scoring Systems. Then these scoring systems were enhanced where it's called DIPS and DIPS plus. D stands for dynamicity. These are the parameters we use to score this system. Age is an important factor. Constitutional symptoms, anemia, WBC count, whether there are blast cells in the bone marrow, platelet counts, whether transfusion is required, and the cytogenetics. So based on this, we score, we give 1, 1, 1, 1, 1. And the DIP says we have to give a 2 score over here. And then we count the scoring system, whether the score is 1, 0, 1, 2, or 3. If the scoring system is 3 and above, like any of these 3 parameters are involved and the number of risk factors are 3, then it's a high risk. So probable survival is just very few, okay, months to years, that's all. And then we have intermediate. Then based on this, the survival is whether it's 2, 4, 7, or 11. All right. So based on this, the survival is defined, and we inform this to our patients. Look, this is a high risk myelofibrosis, intermediate fibrosis, and low risk myelofibrosis, and the survival is on average is similar to this. So in our case, if you see, the scoring system was patient had anemia and patient had constitutional symptoms. So patient is been labeled as intermediate risk 2. So in such patients, the median survival is 4 years. So this is how we give the information to them. And when the survival is on an average 4 years, depending upon this, we plan the whole management of the particular patient. Now, 3 important, very important, symptoms that defines the disease burden of myelofibrosis is, one is the splenomegaly, then symptomatic burden, and the anemia and cytopenia. Based on these 3, the quality of life of the patient is defined. And if there's a massive splenomegaly, a lot of severe anemia, cytopenia, with a lot of constitutional symptoms, the quality of life is very bad and impaired. And based on this, we take a call whether to treat the patient, whether the patient is fit or not. And hence, that's how we take a call in such cases. Very important point, splenomegaly is an independent source of morbidity and impacts the quality of life. So this is the patient with the massive splenomegaly, and then there is a hepatomegaly because the spleen and the liver started producing this hematopoiesis. As a result of which, patient's quality of life is extremely poor. They lose the weight, they get sick, loss of appetite, and constitutional symptoms leads to severe morbidity and impact the quality of life. So reduced ability of the bone marrow to make blood cells results in extramedullary hematopoiesis in the spleen. Because the JAK2 mutations are found in the spleens of such patients. And splenomegaly causes sequestrations of all these cells that leads to cytopenia. And symptoms resulting from splenomegaly are a major factor impacting quality of life. You can see the huge spleen over here, and the quality of life is extremely bad in such patients, leading to abdominal discomfort, inactivity, earlier satiety, and dyspnea. Anemia is a common clinical feature of myelofibrosis, again contributed by the same pathophysiology. So how do I look like in such patients? Most of the times, these patients have left hypochondriac enlargement because of the splenomegaly. There is fatigue, tired, cachexia, patient gets cachexic. There is sometimes pruritus, itching, night sweats, and abdomen pain, muscle pain, bone pain, a lot of non-specific constitutional symptoms, and patient might be moving here and there, might be, the diagnosis might not be arrived at a initial stage because it mimics any other diseases chronic. Patients with MF suffer from a wide range of symptoms. All the symptoms has been described earlier. So it's important, if you have a high clinical suspicious, timely referring to the oncologist is essential to diagnose it and treat it, so that if it's at early stage, low risk, better survival. And the social functioning, cognitive functioning, emotional functioning, all this gets hampered because it's a chronic disease, and patients may suffer greatly impaired functioning for years. That's again an important factor. One important thing is that these patients may end up with acute myeloid leukemia. So it starts with myelofibrosis, and to the other end of the spectrum is acute myeloid leukemia. Again, carries a very grave prognosis. To signal fibrosis cytosis. So these two.
Sir, your voice is cracking. Sir, we are not able to hear.
Am I audible now?
Yeah.
All right. The second important is, because of the disease, there is inflammation, and all this results into fibrosis. So remember, JAK2 signaling pathway, we do diagnose this JAK2 with the peripheral blood or the bone marrow testing. It is done at the molecular cytogenetic labs. So it's pretty commonly we advise this when we have highly suspicious. So this is called dysregulated JAK signaling pathway. By some insult, these are the cytokines that acts at the JAK2 levels. And this, as a result, there is something called JAK2 STAT pathway. This gets activated, and this ultimately cause DNA. At this level, there's increased transcription, survival, proliferation. This leads to cancer. So JAK pathway activation drives the clinical manifestations of myelofibrosis. Why is this important? We have JAK inhibitors, drugs, which is quite extensively being done in the research. And we do often ask our patients whether they are affording to these particular types of drugs. So there are JAK2 inhibitors which have been approved by the FDA. Abnormal cytokine expressions that leads to all this JAK signaling pathway. I've already explained this in my previous slide. And this results in your bone marrow fibrosis. So the crux of the whole thing is the fibrosis. This results in all the manifestations, ultimately leading to cytopenias, anemias, leukopenia, thrombocytopenia, massive splenomegaly. So bone marrow fibrosis is the ultimatum that leads to patient symptoms. Reducing the disease burden is the goal of the treatment for myelofibrosis, because most of the time it's a symptomatic treatment. You manage the symptoms, treat the anemia, try to address the splenomegaly, and minimize the risk of progression and prolong the survival. Yeah, the progression means a lot of times these patients ends up with leukemias, or goes into the advanced stages. So this is the goal of the treatment plan, and more of it's a supportive treatment and a palliative treatment most of the times. We rarely offer specific treatments because they hardly give any results, and overall it carries a poor prognosis. So to summarize this important case, that this pH negative, that is the Philadelphia negative, BCR ABL negative MPN, are clonal disorders that involves the dysregulation of the JAK STAT signaling pathway in the hematopoietic cells. The disease burden of MF comprises three hallmark categories: splenomegaly, anemia, cytopenia, and all the constitutional symptoms. It's a progressive disease that exerts a relentless and debilitating impact on patients' quality of life. This was about myelofibrosis. The next important spectrum, and this will be the last spectrum that I'll be dealing in for today's session, is the diagnosis of polycythemia vera. A brief case scenario. Most of these patients present to us to the emergency department with a 2-week history of clumsiness in the right hand. Okay, this is a real case scenario. The onset was acute, but it did not progress. It denied any left hand difficulties or any problems in his legs. There was no any abnormal from the CNS point of view, like sensory dysfunction, focal weakness, or acute headache. It denied any other CNS symptoms. So neurologically, patient was pretty okay. One important common symptoms that we come across with the polycythemia vera is that this patient now had a past history of non-focal headache, which is commonly, being labeled as, a kind of a migraine-like headache. A lot of patients give a travel history, including a trip abroad where he donated blood and was told that the blood count was high. So usually, most of the times in polycythemia vera, incidentally, the hemoglobin gets detected, which is pretty high, with some non-specific symptoms like headache or some tingling sensations. And the relatives or on examinations tells that the patient face and the hand has become extremely red. That's where you start suspecting the polycythemia vera. Social history is remarkable for the patient being very active. He was a non-smoker, occasional drinker, denied any illicit drug use. No history of neurological and hematological disorder. Again, smoking history is important. If a patient is a heavy smoker, a chronic smoker, then that also can lead to high hematocrit and high hemoglobin. So a chronic heavy smoking history has to be ruled out in such cases. So on physical examination, most of these patients are afebrile, normotensive, and the pulse rate is in normal rhythm. On even the CNS examination, everything was intact. There wasn't anything obvious CNS examination that we come across. This is important. That's why I'm bringing out these histories, because polycythemia causes severe thrombotic episodes, can cause strokes, and can cause all various neurological abnormalities. On examination, especially the dermatological examination, what we observe is red face, which we commonly use as plethora or mild erythematous. That's an important corroborative findings when a patient comes to us with a high hemoglobin. So on laboratory evaluation, based on this suspicious, you see this patient's hemoglobin was 19.3 with a hematocrit value of 61.6%. That's very high. And simultaneously, the WBC count is 6,220 and platelet is pretty okay, 4,45,000. These two are also important because at times these two are also abnormal along with high hemoglobin. Most of these patients have some kind of a headache. So they meet the neurologist, CT scan is done, brain, MRI brain is done, and in most of the times, either it's normal or some focal areas of hypoattenuation can be attributed because of the stroke or infarct. As an hemato-oncologist, we are suspecting polycythemia vera. So naturally, we get a call for such cases. We do end up with doing a bone marrow, and the bone marrow says usually a tri-lineage proliferation. So all the three lines are extensively being proliferated, and no signs of reticulin or collagen fibrosis, because right now I'm dealing with the primary polycythemia vera. Very important, BCR ABL has to be done to rule out which is negative. And in this case, we order for JAK2 V617, which is positive. Another very important minor criteria is serum erythropoietin levels. In polycythemia vera, the serum erythropoietin levels is low. This is important because if you go to a high altitude areas, or if you're a smoker, your EPO levels is generally high, which generally goes against the diagnosis of polycythemia vera. Now, this is the diagnostic criteria, the major criteria and the minor criteria. In the major criteria, we need to have an evidence of erythrocytosis. What are these evidences of erythrocytosis? High hemoglobin and high hematocrit, which goes beyond the normal range. Then do a bone marrow, we see a tri-lineage myeloproliferation with pleomorphic megakaryocytes. And important, which is seen in a lot of more than 90% of the patients, is the presence of JAK2 mutation. In the JAK2, we have two subtypes, JAK2 V617 or exon 12. A lot of times JAK2 V617 is negative, then in certain small percentage of the patients exon 12 comes out to be positive. So both needs to be addressed step by step, and once this is positive, we label this patient as polycythemia vera. One more important criteria, serum erythropoietin levels. This has to be low. This cannot be normal or high in most of these patients. These criteria has to be met. So all major criteria, or either you should have first two major criteria and one minor criteria. Based on this, we proceed with the diagnosis. Overview of the erythrocytosis in polycythemia vera. So the hemoglobin is high, hematocrit is high. Key point, evidence of erythrocytosis is a major criteria for diagnosis of polycythemia vera. A very beautiful diagram you see in the laboratory. This is what, now whenever we withdraw the blood, and this is what happens in normal patients. This is the plasma, this is the WBC, and this is the RBC. Normally, it constitutes 42% of the total normal volume. In a polycythemia vera patient, this 42% becomes increased to 65% in this. Okay, so a larger volume of the picture is being occupied, very high volume of RBC. So as a result of which the hematocrit level is increased. Then we have the bone marrow evidence. We do a bone marrow, and what is the key point? Once again, there is a tri-lineage proliferation, which is a minor criteria in the 2008, but now it has become a major criteria, which is hence we do ask the patient for the bone marrow report. Then we go for the JAK2 mutations. What is this? This is called as mutational analysis test. Usually it's present in 96% of the cases, which is JAK2 V617. In 3% to 5%, we see exon 12. And in 1%, the whole JAK2 is negative. Then we look for other mutation, but it does not have any significant in a clinical diagnosis. So JAK2 V617 or exon 12 mutation are present in about 99% of the patients with polycythemia vera. That's the take-home message for the polycythemia vera. Several conditions results from the overproduction of the RBCs, platelets, and WBC. You see, so far I've been talking about only hematocrit or the hemoglobin in polycythemia vera. One need to understand that this polycythemia vera is a pluripotent stem cell disorder. Hence, it affects all the three lineages, that is the RBCs, the platelets, and the WBC. So on a lot of occasions, all the three are overproduced. So we have high hemoglobin, we have leukocytosis, and we have thrombocytosis also. So one should not get confused that this is not PV. This is certainly a PV because the hemoglobin is high and JAK2 turns out to be positive. What happens in this, whenever there is overproduction, this leads to increased viscosity of the blood. As a result of this, cell aggregates and leads to clots, and this leads to devastating thrombotic episodes and can lead to high mortality. So patients with PV have increased risk of thrombosis because of the blood viscosity, high platelet to platelet interactions, WBC aggregates, and RBC aggregates. This leads to extensive thrombosis within the blood vessels and hence increases the mortality by almost 32% and leads to death in patients with polycythemia vera. What happens? So there is extensive cranial nerve thrombosis, thrombosis to the heart, thrombosis to the liver, thrombosis to even into the intestines. Patient may present with acute abdomen pain, can present with your myocardial infarction, can present with stroke. And that's how things gets complicated, and we end up with diagnosis with polycythemia vera. So platelet to platelet interactions can give rise to platelet aggregates which clots the vessels. Leukocytosis can give rise to WBC and platelet aggregates that promotes again coagulation. So how do these patients present generally? Fatigue, pruritus, night sweats, bone pain, weight loss, fever, spleen pain. Again, non-specific constitutional symptoms that can mimic any other chronic medical disorder, and this might delay the diagnosis. So hence it's important that you have a deeper look into this comprehensive blood, what it suggests, and timely referring the patient and doing the bone marrow and JAK2 mutations can help in decreasing the progression to the further management. Fatigue and pruritus are among the most common symptoms of polycythemia vera. The vast majority of the patients with PV experience these symptoms. Fatigue is mostly prevalent associated with PV. Fatigue was reported regardless of the disease severity, occurring in patients who lacked complications of PV such as thrombosis or splenomegaly. Now you can understand any patient just coming with fatigue, nobody would like to diagnose straight away polycythemia vera. So a lot of basic investigations are required to arrive at a particular suspicious and then end up with the diagnosis. Second important patient do complain to us is pruritus. One should never ignore this particular symptom. Pruritus with high hemoglobin again has a negative impact on the quality of life. A lot of patients complains of this pruritus because there is histamine release, there is basophilia along with this, and which ultimately results in pruritus. Sometimes pruritus is so severe that they end up to the dermatologist and starts diagnosing in all the directions from the dermatology point of view, but ultimately they're actually suffering from polycythemia vera. A very classical presentation is aquagenic pruritus. What they give us a complaint is when they go for the bathing, every day, they end up having exacerbation of the pruritus. So aquagenic is like exposure to the water. Commonly, when they are taking the bath, at that point of time, there is pruritus. So aquagenic pruritus is observed in 60% of the patients. Once again, impaired quality of life, extremely difficult to make the family understand. We have to make them symptomatic free, and abnormal blood production drives this thrombotic complications. The thrombotic complications can be both microvascular, macrovascular. The type of complication depends upon the location of the blood vessels. As already described, macrovascular complications, all the major arteries. Microvascular complications can affect your both the upper limb, lower limb, and sometimes the intestine also. So they come with to emergency with all sorts of thrombotic complications. So microvascular hematological complications could be in the form of transient ischemic attack, headaches, dizziness, blurring vision, redness, burning, and prickling. So they meet all sorts of physicians and specialists, and then ultimately ends up with the oncologist because of the underlying problem. Hematological complications can lead to neurological, cardiac, respiratory, blood. MI, unstable angina, pulmonary embolism, thrombosis, stroke, especially in younger patients or elderly patients, again a problematic. So splenomegaly, look for the spleen. Massive splenomegaly again is an important finding. Sometimes patient has hepatomegaly also. Generally, splenomegaly in polycythemia vera indicates advanced stage, later stages. These patients, although have a high platelet levels, but also at a risk of bleeding because these are not functionally good platelets, and that's the reason why they come out with sometimes bleeding manifestations also. Overall survival is significantly shorter in patients who experience a hemorrhagic event compared to those who don't. So again, an important grave sign. Symptom burden for patient with PV is prevalent and severe. Fatigue and pruritus is the most common symptoms, and this affects the quality of life. Constitutional and other general MPN symptoms also affects the quality of life. It restricts the patient's participation in social and physical activities. There are patients who loses their jobs and then ends up with diagnosis with polycythemia vera, and they feel extremely embarrassing in having a good social to social interaction, depressions, all sorts of problems. A lot of counseling is required to the patient and make them feel good. Thrombotic events, once again, leads to high morbidity and mortality. Apart from arterial thrombosis, we also see that this patient ends up with venous thrombosis. So if you have a patient with a DVT, ultimately ending up with a myocardial infarction or pulmonary thromboembolism. A combination of arterial and venous thrombosis should give you highly suspicious of myeloproliferative neoplasms. We generally stratify these patients into low risk and high risk depending upon the age and whether they have any thrombotic episodes. So younger patients with no history of thrombosis, low risk. Elderly patient or history of thrombosis, straight away classified as high risk. What is the key point here is, another goal of therapy is to prevent thrombotic complications. So if I have a high risk patients, immediately I straight away start with the treatment prescriptions like phlebotomy to reduce the hematocrit, and SOS if that fails, that we also start with hydroxyurea tablet. We also start for high risk patient with aspirin. This polycythemia vera patients, they have a 10-year risk. If they survive for a longer period, ultimately it may end up with myelofibrosis. And from here, it can convert into acute myeloid leukemia. Or the PV in 5% of the cases over a 10-year period ultimately end up with acute myeloid leukemia directly. Either it may take this route or it may directly end up with acute myeloid leukemia. Now, who are those patients who are at a very high risk? Those with advanced age, cytogenetics, or an abnormal karyotype, or when the leukocyte starts increasing, these patients probably are ultimately leading into acute myeloid leukemia. And the risk factors is if the JAK2 burden is more than 50%, or when the WBC count is 15%, these are the patients who ultimately progress to either MF or AML. And this leads to devastating events, extremely poor survival. You see, 5-year survival is only 26%. So there are several other risk factors associated with disease progression. I'm not going into the details of this. Very important, you need to have a good disease control. Why is this important? Otherwise, your patient is never going to get satisfied with you. So manage the symptoms, reduce the thrombotic and hemorrhagic events, minimize the progression. Treatment strategies based on the clinical needs of the individual patients. Also try to understand what is the expectations of the family and the patients, and then take the next step. There are no curative drug therapy for polycythemia vera, and hence it is important that we manage the symptoms, make the patient symptomatic free. So to summarize, PV is the most common of the classical myeloproliferative neoplasms. It is characterized by overproduction of the blood cells, but not just blood cells, because it is pluripotent stem cell disorder. Even the WBCs are elevated and the platelets are elevated. Now what happens? This leads to blood clots. In 99% of the patient, JAK2 mutations are positive. There are two types, V617 and exon 12. Thrombotic complications are a major cause of mortality. Fatigue and pruritus, please do not ignore. A patient coming with fatigue, pruritus, check your hemoglobin levels. They might have a high hemoglobin level. Thrombosis, splenomegaly indicates advanced stage. It's a chronic disease. Overt polycythemia can last for 10 to 15 years also. So you have to assure this to the patient. But over this period, they are at a risk of myelofibrosis and acute myeloid leukemia. The goal of the treatment is make the patient symptomatic free, reduce the risk of thrombotic and hemorrhagic events, and minimize the risk of progression. There is no curative treatment for this. With this, I would like to conclude my session. I want to thank one and all for patiently listening to me, and I'm willing to take up your questions. And thank you for listening patiently to me.
Yeah, thank you, Dr. Pritam Jain. It was a very nice session. Now there is a question, what is the etiology of myelofibrosis?
The etiology has already been mentioned. There are two types of myelofibrosis, primary and secondary. If it's primary, the etiology is unknown. Now you have to get back into the underlying molecular pathogenesis, that the underlying etiology initial event is the JAK-STAT pathway event, which is a molecular level. Okay, so once we suspect that there is myelofibrosis, we want to understand whether this is primary or secondary. If the patient's BCR-ABL is negative, if the patient's JAK2 mutation is negative, then it's a primary myelofibrosis where there is no etiology. It is just a mutational event that has happened inside the body, as a result of which the DNA has been triggered, and this leads to proliferation. If the JAK2 is positive, then the etiology is polycythemia vera, that is leading to secondary myelofibrosis. Or if it could be essential thrombocythemia, that could lead to secondary myelofibrosis.
Is it genetically related?
Yes, most of the time these are, there is no acquired cause, like, patient exposed to smoking or dietary habits or any other personal histories. Usually the etiology is idiopathic. There are mutations that are happening in your body. You are genetically susceptible to those mutations. Some event triggers this, and ultimately you ends up with this particular disease.
Thank you, Dr. Pritam Jain, for giving wonderful information about the polycythemia vera and amyloid leukemia.
It's my pleasure, madam. Thank you very much.
Now, the last ceremony of the program, I request my Assistant Secretary, Dr. Kajal Ahuja, to give the vote of thanks.
Good afternoon, all. I would like to thank our speakers of today's webinar, Dr. B.A. Krishna, Dr. Dipsha Kripalani, Dr. Shobna Bhatia, Dr. Nilen Isha, Dr. Pritam Jain. I also thank our knowledge partners for the day, Sir H.N. Reliance Hospital, Sanofi Healthcare India Private Limited, and Intas Pharmaceuticals, Novartis Healthcare Private Limited. I thank Mr. Deepen Mehta, Mr. Chirag, Mr. Piyush Kale, and Ms. Vaishali Tanpure from DigiShield, who have given us the platform for this webinar and handled all technical details at the same time. Thanks to Dr. Anil Awad and Dr. Usha Shah for conducting the webinar smoothly and efficiently. A big thank you to Dr. Pankaj Bhandarkar for being MMC observer for today's session. Last but not the least, I thank you all the delegates for participating in this webinar in large numbers and making it a grand success. Thank you so much.
Thank you so much, Doctor.
Hello.
Yeah. Thank you, everybody. Thank you, Dr. Pritam Jain.
Thank you. Thank you.
Thank you, Dr. Kajal.
Bye.
Hello.
Yes.